technically we've got 4 hours to play with. We'll see how long it goes on. I won't go beyond 4 hours. It's a long time. But my intention is to give everyone a screen break around about halfway, because I think it could be quite intense, like sitting at a screen for 4 hours. However, as I was saying earlier, I will be getting you to try out some practical stuff. Anybody who's up for that. So Donna, can I get you to mute for me? Kevin, are you all right? Well, just purely because you get that kind of feedback where when there's quite a few of us, it kind of feeds back in. So just let me know you can all hear and see. And it looks like some of you, like Betty, you don't look like you've not got room in there. But my aim is to get you practical. See, there's one of the tests we can do on a chair, and then there's other tests we can do lying down. And I'm trying to give you practical information that you can use straight away. So I think you were, prior to this session, given a question, or sorry, you were asked what your questions are, and the only one I got back was, what is biomechanics? So if you've got any other questions, just post them in the chat box whilst I let Roxy out. So if you have any questions, but hopefully what I'm going to do is I'll definitely be talking about what biomechanics is. And then in the meantime, we are on past, so I will begin. What I'd like you to all do, can you do me a favour and just type, I'm assuming you've all used Zoom before. If not, down at the bottom, if you hover your cursor on the toolbar at the bottom, click on the chat bubble and then post into the chat box, because this helps me when I present in. You can do one of two things, or maybe both. Your preferred sport or physical activity, and if you were to imagine your dream personal training client, would it be older populations, pregnant ladies, rugby players, people with back pain, CrossFit, weight loss? So those two. So if you just put, mine is football, clients football, or mine is bodybuilding, client-wise, I'd like to help people lose weight. And it just helps me get an idea of how to position all the anecdotes that I'm going to go through this session. So if you can do that for me, I'll just give you a couple of minutes to type away. And then it just gives me a flavour then. So have you all done your anatomy and physiology exam yet?
No, not yet.
Not yet, okay. Have you been studying your anatomy and physiology? Yeah, good, okay. How is it? It's kind of challenging, isn't it, when you're trying to link it? Well, how does that help me when I'm trying to teach somebody to squat? So my background is around about 30 years in dance, movement, therapy. And thanks, Kevin. Me too, actually, Kevin. What's your distance? Mine's half marathon normally, but at the moment it's a bit less than that. Naomi hit, good, okay. Older clients are women, great. Jack, thank you. Newcomer to running, yes, that'd be a good project, wouldn't it? And I think you can see quite quick changes with running in terms of a client, so that would be a good one. So yeah, I'm kind of multifaceted. However, I come from a non-academic background, so rest assured I don't have any degrees. I'm super massive fan of simplification in application. So it's all right knowing all about pectineus and obturatus gemellus, but it doesn't help you with a client in a gym. So what I'm going to try and do is assist you all in understanding the importance of understanding the anatomy and biomechanics in your clients, while having like memory connections to why do I need to understand that anatomy. I think anatomy is so complex. You can't know everything about the anatomy. So try not to put too much pressure on yourselves while learning it. Definitely, obviously, study it. And I'm actually just launching some blogs where I'm going through the anatomy of the pelvis, then the spine, then the shoulders, then the knees and the feet, talking about the bones and then the muscles and actions. And what I'm trying to do is give people ways to remember certain things. Like, have you ever heard of the bone, the ischium? You're familiar with the ischium, yeah? So for me, to remember the ischium, I used to remember itchy bum. Yeah, because itchy bum reminded me of the ischium, which is the two sit bones. So silly stuff like that actually makes learning anatomy a little bit more fun, and actually you kind of have reason to remember it. So I'm going to try and help you with some of that. So strength and conditioning, improving strength and muscle mass. Great, thanks, Afa. Kevin, marathon. Ooh. 40 miles or ultra, no, sorry. I haven't got that kind of patience, I'm afraid. Donna, mixture of weight training and HIIT. Connor, Gaelic football. Oh, Gaelic and football. So is that Gaelic football and football?
Yeah, I got
right,
my soccer there.
I'm aware that Gaelic football is pretty kind of loose on rules, if I'm right.
Not too bad.
Yeah, running, build and tone, and then we've got higher Matt. So we're just writing in either your preferred sport or the type of client you're looking for, what their physical goals might be. Betty, resistance training for women over the age of 30, ideal client, fairly new, wants to lose fat and improve body composition. Fantastic. Okay, this is great. So how many have we got? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I was expecting around 14. So we may well get another handful drop in. I'm aware that when you're at home and you're getting set up, there can be all sorts of things going on when you've got kids or family around you. So I'm aware of that. But this is, at the very most, guys, this is going to be 4 hours. It may well be less. It's really up to you. I'm going to try and be as interactive as I can on a screen with you all muted. So there may be points where I ask you to unmute and we might have a conversation based on something. Or if you have a question, just post it at any point. And while I may not do it immediately, I will get to all of your questions. Kevin, ideal client, anyone who is currently unhappy with their lifestyle and needs someone to aid them. Yeah, definitely. I think we collectively now have a duty of care under the current circumstance to kind of use movement as a way to help with mental health. I know Lee Haven is huge on the sort of mental health side of things and helping you guys understand how to be mental health aware. We're kind of restricted, our clients are restricted, and I suspect you guys are going to be restricted right now on practicing your new skills as personal trainers, because it's so hard to train family members, right? Has anybody tried yet? Anybody tried training a family member? Nightmare.
I have, yeah.
Like that, but
it's heated very quickly.
Say that. Who is speaking? Hang on. Who we got?
It gets heated very quickly.
Let me just see who. Kevin. Let's just go Kevin first, then Donna. Kevin, say that again, mate.
Sorry, it gets heated very quickly.
Yeah. It does. Kevin, can I get you to mute? Donna, thank you, Kevin. Donna.
Well, I did it all through lockdown, so I became more bossy.
Sometimes that's the way, Donna.
Enjoyed it. That's
your style, then fantastic. So, right, okay, what I'm going to do, I'm going to go on to, pin my video to the primary video, and then, so because I know we're recording this as well, so that then others can watch back later. Okay. My name is Rachel Francis Thompson. I am a movement geek and I like simple. And over the 3 decades that I've been involved in movement, dance. I'm a British weightlifting coach, strength and conditioning coach, and I have a special interest in biomechanics and the simplification of understanding anatomy and movement, specifically for personal trainers. So you are my perfect audience. You're my ideal clients when it comes to trying to share with you the tactics and techniques that I was taught and then kind of used to enhance my understanding of how can I help this client standing in front of me who has back pain, who doesn't move very well, or who is sedentary, or is an athlete or a bodybuilder with a lagging body part that doesn't grow. So I'm fascinated by the differences between bodies and how we can, as movement professionals, assess and then promote movement to improve quality of life, movement quality, aesthetics, weight loss, mental health, and all that other stuff that you guys have talked about. But in terms of the education piece today, I'm going to share a PowerPoint with you to begin with. Will you forgive me? I'm going to lecture for a little while, then I'm going to get you dynamic, if that's all right. And I'm going to, as much as you want to, I'm going to get you to join in, and we can then, be dynamic whilst we're learning. So yeah, a bit of a mixed background from myself, and I, as I say, no degrees. I'm just a movement geek like yourselves, probably, who enjoys exercise, and then you think, actually, that would be quite a cool job. And, over the 3 decades, I've ended up in education because I wasn't satisfied with the education experiences I had. I was made to feel like I wasn't smart because the style of education I experienced didn't enable me to retain information and learn it, like anatomy. So I'm going to hopefully help you with that. But this is an introduction to biomechanics screening, and it sounds very complex and very technical, and trust me, it can be, but I'm going to hopefully make it really simple for you. And I'm going to introduce you to some I Move Freely techniques that can be mind-blowing and life-changing for some people, but they won't seem like it when you try them. So I'm going to go through this, and at any point, ask a question. It will let me know you've asked a question because it will flash at me, but I will get to it at the point that's right and take a break, because I'll have to come out of the PowerPoint, so bear with me. So we're going to talk about biomechanics, what it is, and its relevance. There's a big thing about being functional right now, which we obviously agree with, but I'm going to talk to you about isolation training first, and then a 3-stage pyramid to your program design, to enable you to consider how you design a program, which will go along with what you're learning with PTI. We're going to, maybe, if we've got enough time, I've done an extra section on core stability, where if you've got a mat, we can have a little play around with. In the practical side of things, I'm going to show you how to test your own pelvis, and then you can do that with your clients to understand whether their pelvis is functioning well or not, how to apply an I Move Freely technique, and if we've got time for this core bit, I'll try and get into that, but it does depend on how we get on time. Fundamentally, our role, even with all the sports and activities you've described, is to improve function and movement. And if you remember, when you feel like there's maybe some overwhelm with a client and you're thinking, oh my gosh, what do I do? That's all you're trying to do, is improve their function and movement. So try not to let the complexities of anatomy get in the way of the simplicity of improving someone's function and movement. That's all we're trying to achieve. The program that I'm going to talk to you about today comes from, it's actually about 30 years now, of gathering data from elite level to sedentary people. So all the clients you've all talked about, and how we can manually or visually ID problems on a gym floor, in a clinic, in a studio, whatever setting you've got set up. And it was work that we put together based on our studies, but also studies from world leaders in biomechanics. So you may or may not have come across Stuart McGill, Toomey Taylor or Grakowetsky. Stuart McGill is somebody I'd recommend. So have you got pens and papers, guys? I'll give you a few book recommendations because I'm aware that Christmas is coming, and some of you may want to kind of, you know, put some of these on your list. So Stuart McGill, who is a world leader in spine biomechanics and core stability training. So he's done around 800 odd studies on the trunk or the core under load and what is safe, what may not be safe. So that book, Ultimate Back Fitness and Performance, Stuart McGill, Ultimate Back Fitness and Performance. I've got it here actually. Is a great book for movement professionals. So we did some clinical low back pain books, but that book is a great one to help understand. And if we get to that section later on, hopefully tonight, where we're going to talk about progressive core stability training. So he's a font of information. So a little book recommendation. But trying to appreciate our own scope of practice. So you are likely to get, if you haven't already, clients who come along with back problems, knee niggles, shoulder niggles. I'm sure you guys have experienced a dodgy wrist or a niggly back. And we've got to understand where our remit as a personal trainer starts and finishes. And so I'm going to try and help you appreciate that a little bit more by giving you an example of what biomechanics is, what it isn't, and where pain maybe fits into that. So we've worked with several organisations, and I won't spend too long on this. I want to get into the information, but I'll just put that out there. So if you do have any links to, I don't know, I'm just trying to look at something on here. So for example, one of the universities, if any of you move to America, we've got accreditation over there. Another one here. So if any of you are interested in football, was it Jack or Connor, one of the guys, sorry, said you were interested in football or Gaelic football, and then I may be able to give you statistics around those fields of sport where we've definitely had links already. The learning process can feel a little bit like these kind of 3 stages of emotion that Elizabeth Kubler-Ross actually put together when you suffer bereavement. But I think during COVID, we've probably experienced some of these feelings. When you heard about in March that you had to stay in your home, the shock, the numbness and the denial, gosh, this can't be true. The fear about paying your mortgage, the anger, oh my God, this can't be right, and the depression. And then you just get into that phase of acceptance and moving on. And the learning process can feel like this sometimes. You go into these different phases of, gosh, overwhelmed, this is a lot of information, and then you feel good and you're like, no, this is great, I know what I'm doing. So it may be that some of the things I talk about today have the same effect on you. The learning process is supposed to feel a little bit uncomfortable because you're exposing yourself to new information and new paradigms. What I'm trying to say to you is that's okay. That's a point of growth. That's a point where you know you're learning something. That's when I'd like you to ask me questions. All right, so just post away when you've got one. If we think about the history of our role as a movement professional, as an exercise professional, exercise many years ago originated in bodybuilding. You may have heard of a gentleman called Arnold Schwarzenegger, Muscle Beach, Gold's Gym. Global muscle performance was basically squats and bench and pull-ups. And it's more sophisticated now. We call it functional training, same thing. It's still global muscle performance. But what happened was somebody came along and said, well, hang on a minute. These guys need to have a strong and stable core first. So core training, Pilates, CX work started to then come on vogue to help us perform better by giving us that solid trunk to move through our squats and push-ups on. The problem is we haven't regressed back far enough yet. And this is where I want to focus this session on, is how do we prepare our client's body for core stability training? Let me give you a very quick example. Imagine that you have a sore back, or your client has a sore back. They're a little bit wonky in the mirror. So if you looked in the mirror and you look like one shoulder's a bit higher than the other, so you're a bit off center, or your client is, what do you think would happen if you then strengthened that position? Chances are it's probably not the ideal position to strengthen. So what we're going to focus on tonight is the first layer in this pyramid. So this pyramid, I want you to really think about your program design. Prepare your client's body to move. Get them moving well first. Use some techniques. You're probably familiar with foam rolling, trigger pointing, stretching. I'm hoping to introduce you to some new techniques to add in there so that when they do their core training, their body is a little bit more level and a bit more symmetrical and aligned. Then when they run or squat or bench press, they're in a better position. They're going to be stronger to do that. So I hope that all makes sense. But ultimately, prepare, stabilize, and then the function and performance piece on top. So that's your kind of program design pyramid, if you like. So I know the only question I got sent by Lee was, what's biomechanics? So biomechanics is very simple in one end of the spectrum and very complex in the other end, all of which are what we classify as extrinsic. So the simple end is the body's mechanics, the biomechanics, your movement quality. So when you watch your client doing a squat, and as a personal trainer, we are coaching them to keep the back up straight, shoulders back, knees in line when they do the squat. That's kind of, if you like, the simple end. So all of you guys are already learning about biomechanics. And then you've got the very complex end, which is forces, vectors, first, second, third class levers. It's the very complex end of white lab coats and very mathematical equations. So there's this whole spectrum of extrinsic biomechanics, which is what you see when your client moves. So the focus for tonight is going to be on the intrinsic biomechanics. So the intrinsic biomechanics is the muscles, the bones, and the nerves. And these will work together to produce what you see on the outside. So let me try and give you an example. Your client comes in, they do a squat and the knees cave in. What's the first thing we do? We'd say, right, okay, stop. What I want you to do this time is push your knees out, right? That's how we're trained as personal trainers. So what I want to open your mind to is, imagine that this client has been sitting at their desk for 9 hours and the muscles in the buttocks and the back of the legs have started to adapt to being very static. They're squashed against a seat. And so what's happening is the muscles are adapting to that posture. So when they stand up, they're not really functioning to their full capacity. So what we want to consider is that limitation causing them to move badly, or is the knees falling in technique? And this is what I want to differentiate for you, is when you're coaching somebody whose knees are caving in, can we test the pelvis to see if there's a problem there and then improve the function before we start to ask them to push the knees out? Because it may well be, because they've been sitting down all day, we need to do something in advance of the squat to prepare the pelvis for movement. So I hope that makes sense. If you need me to clarify anything there, please do post a question. Okay, so anybody who's watching this who is able, I'd like you to just push your chair back, stand up for me, find a space. Go on, off you go. Come on, Donna, I can see you. You ready? No pressure, Donna. Let's see, who else can I see? Oh, I can't see when I'm on share mode. Let me just do this. Let me stop share.
Okay, I'll do it.
Brilliant, well done. Right, let's have a look at your... Right, okay, Jack, Kevin, Matt, Naomi, Donna. Right, whoever can. Find your space. You ready? If you have any ailments, then please don't put yourselves at risk. I'd like you to just sit on your haunches. So just try and see if you've got your feet flat on the floor, heels down, Can you get your bottom down onto your heels? Ooh. Yeah, how does that feel? How does that feel? So Jack, how you doing? It looks good down there. Kevin looks good. Donna, I can just see your head. Betty's having a go. Brilliant. So, okay, you can all come back up again. So, if you were to ask all of your clients to do that, and you might not, what you would probably notice is that everyone's width of foot, don't worry, Betty, that's all right. I'll show you again in a moment. You can have a go. The width of your feet. So, for example, some people would be here, some might be here, some might be out here. Also, the angle of your foot, the angle of the tibia. So, Betty, if you imagine this is my squat, other people may have been, and I can't do it, may have been here. Somebody else may have been over here. Somebody else may have not got so low. The point is, there are things about our client's squat that we cannot change. Whereas there are things about the squat that we can change. So I'm going to ask you guys to tell me, if you post into the chat box, what can you never change about your client's squat? What about their physical anatomy can you never change? In simple terms, when you look at somebody squatting, what impacts on the way they squat? So anything, natural hip width, yes, Betty, perfect. Structure of the spine, yes, exactly. So the length of your femurs, the length of your tibias, your joint geometry, all of that stuff. Now I've got another question for you. What can you change? Well, let's see if the others put some answers in there as well. And how would you change that, Ava? How would you change the depth? Distance of the feet, how would you change that? Mobility, yes, Kevin. So you change mobility through mobility training. So that's joint mobility. So that's the movement of the bones of the spine or the hips. What else? Can you remember the three substructures? So Kevin's talked about mobility of the joints. Range of motion, Naomi, perfect. So what could you use or what system within the body could change the range of motion? Mobility would be one. What other system structures or soft tissue have you got in your myofascial? Yeah, perfect, Kevin. So you could do muscle flexibility work, so stretching or PNF would improve the range of the myofascial system. And then also something you may not have spoken about yet is nerve mobility. So you could change joint mobility, muscle flexibility, and nerve mobility, but you cannot change pelvic geometry, femur lengths, and natural genetic makeup. So what I'm trying to do here is help you to not have too much pressure on yourselves about what you can and can't achieve about your client's squat. Because a lot of clients will come and say, I want to squat like Barry. Well, if you're not built like Barry, you're never going to squat like Barry. So our job is to raise confidence in our clients about what they should or could or maybe can't or maybe won't be able to achieve when they're moving. Does that all make sense? Yeah, cool. So here's some examples as to why we are different. So you've just mentioned about the sort of differences in the osseous sort of structure. So Kevin was talking about the bones, and this is the top looking down at the head of the femur, of the femur neck. So you've got the femur going down away from you on this image, and we're looking down on the top of the greater trochanter, the head of the femur and the femur neck. And you can see the angles are different. Here you can see from the front view, the angle of ab and adduction on the femur in relation to the angle at the neck. And again, the different lengths of femur. So the one in the middle is much longer than some of the others. And here on a pelvis, the actual acetabulum on some pelvis Apparently the plural for pelvises is, by the way, is pelves, P-E-L-V-E-S. I learned that quite recently. So it could be angled forwards or it could be angled more laterally. So just think about, how is that going to impact on the way your clients squat? It's going to change their preference for their foot width, isn't it? Because if they've got a more lateral pointing acetabulum, a wider squat may be preferable. Whereas if it's pointing more forwards, like the left-hand image, then maybe a narrower foot position. You can see how that may be the case. Can you see that? And then if you're looking at different pelves, so the different sort of heights of pelvis, widths, male, female pelves are different. So it's just trying to help you understand, while you're learning anatomy from a book that is very two-dimensional, this is one representation, and then the skeleton is also only one representation. But every single client you get is likely to have a different geometry and genetic makeup. So it's not you, it's them. So look, these are all athletes. Yeah, these are also all athletes. So it's the beauty and the frustration when you come out of personal training school, that all these wonderful specimens of different bodies and different movement styles, it's not necessarily what you're doing if they don't move in the way the last client did. It may be just their design. So I'm trying to give you a comfort blanket here, guys. So we've talked about the muscles, the nerves, and the joints and how they interplay. One key aspect I want to really kind of emphasize here is your body is an integrated system. So if you had a logo on your front left breast, on your t-shirt or your sweater, and then you take the bottom right hand corner and pull it, that logo is probably going to move. And your body is interlinked in the way that if you release a muscle over here, it can impact on a muscle over here, maybe release the shoulder over here, and then the nerves down here. So by improving one area of the body, you can improve potentially far more parts of the integrated system. So in simple terms, we were designed as hunter-gatherers to sit on our haunches. Our more recent culture, if you like, is that you're probably all sitting on a seat or a chair, and you're probably having your hips fixed around about 90 degrees if you're sitting upright, maybe a bit more than that if you're forward flexed. But generally, you're probably all sitting with about 90 degrees of hip flexion. Am I right? Am I right? So what happens is your hips start to adapt. Your brain is thinking, well, I'm not using those muscles. That's a waste of energy. I'm going to make them more ligamentous. And then when you get up and move, you're a bit stiff and you want to move and wriggle around. But what happens is if we do this repeatedly over time, we gain these compensations so that when our clients come to us with these stiff backs, stiff hips, we're getting them running, we're getting them squatting, but we're actually potentially enhancing the movement problem. So let's think about that pyramid again and consider preparing the body first. So the body that we strengthen is actually in a better position. So when they do run and squat, then they're improving the movement pattern. Natural movement is where we want to get to. That's where good quality movement and function and reduced pains and niggles comes from, to be fit for our purpose. So I'm going to bring Skelly in. So I'm going to come out of screen share and bring my friend in. So hopefully you can all see. And I'm just going to talk about one adaptation that's quite common that we're going to test for later. And you can do that test with clients. but I'm going to talk about the amount of compensations that can come from this one problem. So, can any of you give me any movements? And by the way, none of my questions are trick questions. It's always the simple answer. How many ways do you understand the pelvis to move? If you can remember, if anybody wants to have a go, just type in the chat box. If nobody types, I will tell you the answers. But I like to just see if anybody wants to have a go, then I'm a fan of you. So maybe just have a little go. If anybody can think of just ways that the pelvis moves, you can use any language you like. Betty, anterior, posterior. Perfect. That's exactly what I was after. So anterior is when the pelvis tilts forwards. Posterior is backwards. Can anyone give me one more? And then lateral. So Kevin, yeah. So lateral would be when you're walking, the pelvis rotates either side as you walk. Perfect. Great stuff. So that movement of walking, let's just focus on this one for a minute, is around this joint here. Does anybody know what that joint's called? Can you remember this one? There's your sacrum and there's your ilium. So that joint is, which joint is that one? I'm testing your anatomy now. The ischium is this one. Remember itchy bum, Naomi? Itchy bum is down here. So good on that one. Kevin, yes, sacroiliac joint. So in here, Naomi, we've got the sacroiliac joint. So it's where the sacrum and the ilium meet. That's where the movement of walking comes from, among other joints. But what can happen is, can anybody remember piriformis? Do you remember piriformis? You come across that one? I'll tell you because you can't show me. So unless you know the bony landmarks, piriformis comes from. Can anybody remember the two bones? Or any of the actions of piriformis? Can anyone remember? By the way, let me teach you a trick. Just get your anatomy book out or your phone and Google it.
Is that
Yeah?
external rotation?
Perfect, thank you. Yeah, and what does it externally rotate?
The femur.
It does, so it must attach to?
The femur and
Brilliant.
the sacrum.
It's fantastic. And actually it's dead easy when you put logic to it. So it rotates the femur laterally. So then where does the other end need to go, Kevin?
To the pelvis.
It has got to go to the pelvis. It's going to cross here and it's going to attach to the front of that sacrum. Can you hear my dog? Roxy, please. So top of the femur, across to the front or anterior of the sacrum. So can you see how, if it was to shorten, it would laterally rotate the femur? Yeah, can you see that? And it will also abduct the femur. You see that? Now, the reason I talk about this muscle is because it's a common one for people to find is either uncomfortable or it limits the movement around this sacroiliac joint. And it's also got a close relationship with a specific nerve. Do you know which nerve it's got a close relationship with? Anybody know the nerve? Come on then. Sciatic nerve, yeah, perfect. So the sciatic nerve passes down the spine, down the back, and then down the leg, and it has a relationship with this muscle, the piriformis muscle. So if your piriformis muscle is tight, short, dysfunctional, it can actually tether on the nerve and limit movement through the back of the legs. Yeah, so we need a good functioning piriformis muscle and other muscles. So you've got your glutes over the top, glute max at the back, minimum med at the side. So let me just talk about now how if this muscle becomes a problem, and let's say it becomes a problem, so if you imagine, let me just go through the gait cycle. So as your leg steps forwards, this side of the pelvis will rotate up and back. And as the leg steps back, the pelvis will rotate forwards and down. So if that muscle adapted with the leg forwards and the pelvis rotated up and back, this leg if you were to hang them from the ceiling, would appear shorter, right? If it got stuck in the other direction, when the pelvis is rotated on this side, forwards and down, it would appear longer. But this is a functional leg length discrepancy. It isn't structural. It's not what you were born with. It's because the hips are restricted or limited in their movement quality, and it gives the appearance of a leg length discrepancy. What can result in that is if your client has a functionally long leg, they may buckle in at the knee and then complain of knee pain or shin pain or foot pain. But is the knee, the shin, or the foot the problem? No. But they get the knee treated by a therapist who they think is rubbish because their knee still hurts after a week because it's coming from the pelvis. And we can help with that with exercises. If you imagine the compensation going the other way, so instead of the long leg bending the knee in, the ilium sits higher on one side. So you will naturally bring the head in line. But what's now happening is you're loading the spine and the back. And what do our clients then complain of? Back pain. But the back isn't the problem. It's the pelvis where they've been sitting that's adapted and become dysfunctional. So if you and I as personal trainers can assess this and understand it better, then we can reduce tension on the back, tension on the knee, improve their quality of movement, and hopefully that all makes sense. Does that make sense? It's a good example of the integrated system. You've also got a direct biomechanical link between the pelvis on one side and the shoulder on the other side through the myofascial trains. So another great book, Thomas Myers, Myofascial Trains, talks about the lines through the body, which is why we walk with a rotation rather than kind of using the same leg on the same side. You've got this torsional component in our movement quality. And so when we understand how the body works as an integrated system, as coaches and trainers, it enables us to really understand when, if they have a sore back or a sore knee, actually, if we improve their pelvis function, we can potentially reduce the back, knee, foot issues. Does all that make sense? Yeah. So this adaptation that I'm talking about in the muscles of the hip is not necessary. It's not like a muscle spasm where you bend over and you get sharp pain. You are completely unaware of it, or your client is, other than they feel a bit stiff. It's just the muscles started to adapt. We call it subclinical because it's not painful, it doesn't hurt. Over time, it will eventually just become tight. And we all know what we do about a tight muscle. We stretch it, or we might do. So what I'm going to introduce you to are techniques to address muscle spasm or subclinical spasm that is not yet tight, so they can still move well, or with a limitation, and introduce you to some muscle energy techniques, if that's all right with you guys. So as movement practitioners, if we can assess the client at the beginning, I'm going to give you some pelvis and spine function or biomechanics tests. We know where to get our clients prepared, ready for their program. We've gone through that. So pelvis biomechanics, you ready? So I talked about a moment ago, this leg length discrepancy. Structural leg length discrepancy is when somebody is born with different length femurs, and that's actually quite rare. The more common structural leg length discrepancy is usually when somebody has a knee implant, a hip implant, metal plates in their ankle, or they've broken a bone in their lower limb. But more common than that is what we classify as a functional leg length discrepancy. So I'm going to show you an example here. So this is a 400-meter sprinter who came to us with left knee pain, and she had seen all the clinicians, she'd had MRI scans, and they said, there's nothing wrong with your knee, it's in your imagination. So we had a look at her pelvis function. We actually found that her left leg, can you see the ankle bones in the middle there? Can you see how the left leg looks a little bit longer? Or the right leg is shorter. So one or the other. So we looked at her from the side and we asked her to bend the longer leg to level the pelvis, and that's how much she had to bend it by. That's quite a bit. So, you know, it's not surprising her knee was sore. If any of you have ever run on a track, that's actually the inside leg on a track, which is, they always go kind of round to the left there. So that's the wrong leg to have long. She could have got shin pain or foot pain. So we ignored the pain and we assessed her pelvis function, like I'm going to show you later. And actually, when we gave her an exercise for the pelvis, after 2 weeks, she was pain-free. And 2 weeks after that, she was sprinting again faster than she was before. So it wasn't the knee, it was the pelvis. But where the knee is beyond our remit because it's sore, you think, well, I can't do exercises that harm the knee, that hurt the knee, but you could provide an exercise potentially for the pelvis. The other example that I showed you with my friend in the back here is where the movement changes and what happens above the pelvis. So the video on the left is a nice level pelvis, and when they rotate, you'll see they rotate through a nice center of gravity. Whereas the image on the right, you can see how the pelvis is slightly off, and there'll be a hinging in that right side of the spine. So there you go, nice movement round. And then on the right hand image, see how the upper body is kind of gapping, and you've got a hinge in that bottom right hand portion of the spine. So we really want to identify this as personal trainers before we start writing the program and help them move better. Just some stats here. In fact, let me see if I can't move you guys over this way. Let me move you down here so that when I put you back on, there you go, you're out the way now. Right, so knee injuries. Motion impairments at the hip can result in ACL tears, IT band syndrome, knee pain, and you may be familiar with some of these. So it's our job to improve movement, but we could work closer with the medical world to improve the knee loading from the pelvis while they treat the knee. ACL, 91% of subjects with anterior cruciate ligament injuries had pelvis dysfunction. And that's, again, something I'm going to show you later on. And hamstring injuries, again, it's all linked together in this integrated system. So while you guys are not injury specialists, you're not medically, well, I don't know, sorry, forgive me if any of you are medically trained, but as personal trainers, we don't have a clinical knowledge. That doesn't mean we cannot work with our clients. As long as we work with the clinicians, we can holistically improve their movement while they get treatment with a clinician. Somebody's joining in, welcome whoever that is. So everything I'm talking about is based on evidence. And we did a study with a group of subjects that were registered disabled with low back pain for 2 years or more. Now, statistically, 10% of that demographic will get back to work. Within a 6-week period, we'd put 97% of them back to work. It was not clinical. So where the clinicians were failing them, so example on the graph here, standard physiotherapy treatment will improve back function by 39% in 6 weeks. We improved back function by 141% through the model I'm going to teach you tonight. Because a lot of people in pain, it isn't a clinical issue, it's a biomechanical issue. And that's our job. That's our role as movement professionals to improve their quality of movement. Statistically, nerve mobilization, so range of motion before and after nerve mobilization is not a huge statistical difference, but after in range of motion, but speed of movement. So for those of you who, I think somebody out there was an Olympic lifter, you need speed to get the bar overhead. If your median nerve is tight, that's going to impact on performance. 200% improvement in spinal velocity in some of the tests we did. If you're running, so me and Kevin like to run, probably not as fast when we're doing these ultra marathons and half marathons, but you still need to be able to move and not get injured. So understanding how speed relates to movement as well makes it interesting. There's also a lot of statistics out there, and this is just to let you know how important your job is as a personal trainer when it comes to the evidence for injury prevention. Strength training has more benefit than stretching to reduce injury risk. Or proprioception work. Are you familiar with proprioception? Balance work, body positioning, coordination, which is again what you specialize in. So people always talk about, oh, stretching is the injury reduction technique. Actually, maybe not. So it doesn't mean you don't stretch, but it's actually conceptually, you need to help your clients be strong, mobile as well, but also strong to really reduce their risk of injury. So who would like to learn a pelvis function test? Anybody? Yeah, let's see who we've got out there. Let's have a look, see who I can see.
I'll do it.
Brilliant, Jackson. Right, okay, Jack, fantastic. So if you've got a chair, let me go on to gallery view so I can see you all. If you've got a chair and you want to join in, if not, you could just watch me. I'm going to grab my chair and grab your chair. And this is a pelvis function test, super simple. All right. So in your chair, let me bring you down a little bit. Got my sit-stand desk. The brilliance of IKEA, just bring you all down a little bit there. Good old IKEA. Okay. So ideally, you would have a standard 90 degree at the hip, and then you're going to cross one ankle over the opposite knee. So are you able to get into that position? Yeah.
Yeah.
And then get a sense of how high your knee is from the floor. Yeah. Now swap and compare to the other side. Can you see how mine is lower on this side, but it's higher on this side? So do you have an asymmetry? So is one lower and one higher?
Right leg is higher than the left.
Right, okay. Congratulations, Jack. You have pelvic dysfunction.
Happy days.
Me too. Donna, what about you? Were you symmetrical or not?
I'm sure I was too high, I couldn't do it.
Okay. Anyone else got a result? Betty, what you got? Symmetrical or not?
Fairly symmetrical, yeah.
Okay, good, fantastic. So you passed. Matt, how about you? Were you able to do it where you are?
Yeah, I found my right leg is quite a bit higher than my left.
Okay. And Naomi, you're just watching what everybody's doing and being a coach to see how well they perform. Yeah, great. Connor, and I've got one person in there that's just coming up as iPhone, so apologies, I can't see, I don't know what your name is. So Jack and I have an asymmetry, Matt has an asymmetry. So if we were our personal training client, that would indicate, right, we need to do something before we actually start them on their program. So what I'm going to introduce you to is a pelvic muscle energy technique. So you've probably have you done PNF yet? Have you studied PNF yet? Are you familiar with muscle energy techniques? No, okay, don't panic. I'm going to teach you. Right, okay, that's the point of us being here, isn't it? Okay, so if you imagine a stretch, which is what we learn on our personal training courses to help with our muscle flexibility, is when you take the muscle origin and insertion away from each other. That's a stretch, right? And that is going to impact on the Golgi tendon reflex to improve movement quality. That's the idea behind it. A muscle energy technique is the opposite. So we're going to bring the origin and insertion of the muscle closer together in a static, isometric muscle contraction. Do you remember what isometric means?
Still.
Yeah. Jack?
Still.
Yes, static. So a static contraction. Now, there are a variety of ways of doing this, and PNF may be one that you learn in subsequent training with PTI. That's one version. I'm going to teach you a different version. Now, this version, anyone can do. Like literally, Naomi, you could do it in that position there. You could literally just put your leg in a position. You could do it right there. There is no effort required. So you're going to go back to your seats. And then from here, you're going to go back into this position. So what I'd like you to do is, because we're going to do an isometric contraction, which means you're not going to move, I'm going to show you the movement that you're going to do when you're not moving. Does that make sense? So the isometric movement is going to be internal rotation of the femur. Yeah. So this movement. So you're going to rotate the top leg across the body, and you're going to push the foot into the opposite thigh. So you're rotating the femur. Yeah. That's it, Jack. You got it. To do it isometrically, we need to put our hand onto the inside of the leg to stop the movement as a block and give it the isometric component of resistance. So hand on the knee, rotate the leg, the hands block the movement, and you're going to hold it there. Now, I only want you to apply 20% of your maximum effort. So this is from your hip muscles. Imagine your hip muscles turning your leg, pushing against your hands. The hip muscles, only 20%. You ready? So hand on the inside of the knee, 20% effort. The hands are just the block, and we're going to hold it for 20 seconds.
All right, let's go.
Hold it, hold it. That's about 20 seconds, isn't it? Take the leg down. Do it again. We're going to do 4 repetitions, all right? So back into position on that right side. Lift the leg using the hip rotators or the hip movers over here. 20% effort. It's a little bit difficult to believe. What's that going to do? For some of you, you're probably thinking, I don't know if I'm doing this right. It doesn't feel like I'm doing anything. If you are lifting your knee with your hip muscles into your hand, 20%, you're doing it right. Take the leg down, bring it back up. 3rd rep. Fantastic. So the movement, just to remind you, whilst you're doing that, is this. Your hands stop the movement, and it's 20%. Held for 20 seconds. So the 20-20 muscle energy technique. Is this 3 or 4? This is 3, right?
3, yeah.
Yeah, bring it down. Bring it back up. Let the hip relax. Hand on top again.
Can I just ask which leg we're supposed to be doing that on? Say if one leg was higher than the other.
We're going to do both, Matt.
Both.
So we're going to do both.
Right.
When it comes to exercise, it's a good point though, Matt. I'm glad you asked it. We would always prescribe exercises for both sides of the hips. Even if you've got a higher one side, I would always encourage you to do both sides. Yeah?
Okay.
So we're going to go to the other side. Was it your right leg was higher, Matt?
Yes.
Right, okay. Are you doing your left leg just now?
My left leg, yeah.
Right, let's go to the right leg, because you're like me, you're on this side. So we're going to do the same on the other side. So again, rotation, hand on the knee, rotate into the hand, 20% effort. So what we could be doing at this point with a client, whilst we're coaching it, is saying to them, so how was your day? How do you feel? You know, this could be part of the initial consultation when they come in. And you've done the pelvic function test. They're a little bit different. You can say, right, we're just going to prepare your pelvis before we go in the gym so we can do this. So tell me about your day. And whilst they're practicing this technique, let's go down, bring it back up, hand on top, and rotate. And we can start to talk to them to make sure that those 20 seconds, we may check their pressure, put our hand onto the leg, and check they're doing 20%, which is that low level. And they may ask us, I don't know if I'm doing it right, can you check? And you just put your hand on the knee when we're allowed, or with gloves on. and then take it down, bring it back up. 2 more, right? Yeah. So I would say to you guys, so those who are practicing this, if at any point you feel different, you feel a change, then you just say so. Yeah, you can type it or you can say it, as long as we're not all speaking at the same time. So that's the third contract. That's the third static hold at 20 seconds. Bring it down. Last one, right? So in total, 2 minutes and 40 seconds. And what we can do immediately is redo the test. Yeah, once we've done this last one, we can then bring the leg down and redo our initial testing. Yeah. So bring the leg down. So there you go. Right. Okay. So let's go back to the test. Cross one ankle over the knee and see if you feel like the knee's dropped, you feel different, or you're more symmetrical now. And if you've got a change, type yes in the box, wherever the box is. Is the box over there or there? I never know when Did you get a change? Type yes. Donna's got a change, amazing. Jack's got a change. Matt, how did you get on? Matt got a change. Good. And I know some of you may not have done that. That's fine. So I'm going to send you all an invoice afterwards. Is that all right? No, I'm joking. Betty got a change. Brilliant. Now then, interesting. Betty measured symmetrically, but she still experienced a change. So can I ask you, Betty, what change did you feel?
They're just down ever so slightly.
You felt like they dropped a little bit?
Yeah.
Amazing.
Yeah.
So you can see how quick we can do a test, a technique, get a change, and prove the value of our services as a personal trainer. It's immediate. Now, chances are you get up, you move around, it'll come back. So we need to then apply the strength training on top of that to reduce it going back there while we educate them on lifestyle, and you can't sit at a desk for 9 hours solid, you need to move around. But the beauty of the technique, where could they also be doing it? They could do it at work. They can do it while they're writing an email or reading an email or on the phone. They can do it whilst they're having the breakfast. So they don't necessarily need to be doing it in your session. We can educate them and equip them with the ability to do that through their day. Yes, they want to do that repeatedly. Does anybody have any questions? So 20% effort, hold for 20 seconds, 4 reps either side, and the test is called the 4 sign, because you're putting the legs into the shape of a number 4. So it's the 4 sign pelvis function test. And the exercise is called the 4 sign exercise, because your legs are in the shape of a number 4. Any questions on that pelvis function test and exercise? And I can send you this PowerPoint, guys. I've got no problem sending you the slides.
So
Any questions?
would you do that every time with your client?
If you test them and they've dropped, but I guess it's a good question, Donna, because like Betty, even though she tested okay, she still feels better afterwards. She feels like she's moving more freely. So you might want to do it as their warm-up, or it might be their warm-up preparation. So you do that first, then warm them up on a treadmill or whatever your warm-up is, and then you do the session. But over time, ideally, you want them doing that before they begin. So the first session, you teach it to them, and then you say, right, next time, do the 4 sign before you start, and then whilst you're waiting for me, you can do that outside, and then we can just crack on with our session. Or you may say, what I'll do at the beginning of each week, I'm going to test your pelvis and your spine, and then we'll see what we need to do. Because it's ideally what the tests are doing, they're guiding what you're going to do with your client in that session. Because if they your biomechanics is very dynamic. So you guys will know if you've sat in a car for 4 hours driving to an event or a workshop, you feel stiff. And you may have the day before tested really well, but on that day you test very positive, like it's not looking great. So you can use the test at any point, but ideally before a session to know if they need some preparation work prior to getting them moving.
Okay.
But it's a good question, Donna. Any other questions on that technique? Okay. So let's talk a little bit. Let's have a look what we got, what time we're on. Okay, let's talk a little bit about, let's share my screen. There and there and there. Okay. So if you are, let me just go backwards, just go here. Right, okay. So that is the test and exercise we've just done. There's the test. So negative or pass means they were symmetrical. Positive, which is a fail, which is like your blood test is positive, is when you're asymmetrical or quite high. So if somebody tries to get their leg over their knee and they're struggling, they're probably going to benefit from the technique. So it's to minimize the risk of hip pain, and ideally we want to have the knee symmetrical. So then when we look at our strength training program, have you yet looked at what's known as the law of reciprocal inhibition? Have you come across that yet? In fact, let me come out of that just in case. Have you studied the law of reciprocal inhibition yet?
I've heard it mentioned before. It's been in other courses.
Yeah, okay. It's really simple. It sounds like a fancy name. And when people chuck things like that at you, you go, oh, am I supposed to know this? That sounds really complicated. It is simply when the agonist contracts, the antagonist lengthens. That's all it is. So the body is designed. Fantastic. Thank you, Betty. In your books, 45 to 47. Brilliant. Thanks for that. So reciprocal inhibition is where you learn about the agonist-antagonist relationship. Yeah. And when you learn at level 2 and level 3, you understand that muscles work in pairs. And when one side of the body contracts, the other lengthens so you don't get injured. Yeah. Because if both contract at the same time, all sorts of things will be going on. So in the technique we've just done, we are probably influencing the piriformis muscle in the hip, which we know is an abductor of the hip. Yeah, just to keep it simple. What would be the antagonist even movement to abduction? What's the opposite of abduction?
Adduction.
Adduction, perfect. So we're going to take advantage of the law of reciprocal inhibition, where we've released the abductor, the piriformis muscle, doing our 4-sign exercise, muscle energy technique. We're now going to strengthen the opposite, the adductors. So can you think of an exercise that would, or demo, if you like to demo, that would strengthen the adductor muscles of the hip? Let me do that.
There's a form of plank you can do with the leg up on the bench.
Yeah.
And then
which leg? The bottom leg or the top leg?
the top leg.
Perfect. So yeah, exactly that. So you would have your top leg on a bench and your top leg would lift your body off the ground. That's quite an intense one, actually. Sorry, I haven't got your name. What's your name?
Kevin, I got cut
Kevin.
off.
Oh, you keep changing. It is Kevin.
I got cut off on the PC.
Oh,
so
right, okay. It's like, who are you? So yeah, so an advanced technique to work the adductors would be top leg on top of a bench, so the knee on a bench, and then the top leg would lift the body off the floor like a side bridge. Does anybody know an easier one? A simpler one?
Raises.
Who is that, sorry?
Naomi, side leg.
Side leg raises. So this way,
Yeah.
So that would that be abduction or adduction?
But you can cross it over the front. So like if you're holding onto a chair,
Yeah. So do you mean?
like a pendulum sort
So
of.
do you mean that way?
Yeah.
Right, okay. So technically that's adduction, but there would be no loading. There'd be no, you need some resistance. So
You know,
how, say again?
can you use ankle weights?
There would be a piece of equipment that's better than that for that particular move.
Resistant bands?
Yeah. So if you've got a resistance band over here, tied around the ankle, and then you pull the leg across, perfect. If you've got an ankle weight and you were to lie on the floor and lift the bottom leg
Up.
that would be adduction strength work. If you work in a gym, you've got seated adductor machines, right? Yeah, that would be another one. Pilates ring, between the knees, squeeze it. Stability ball, squeeze it.
What
Lie
about
on your back, open your legs, squeeze in and out. The load would be then the weight of the legs. Yes, Naomi?
in gymnastics? We would use like butterfly. You know, like where you sit with your feet on the floor, you know, and then you bring your heels into your bum. No, I mean if you're sitting on the floor.
Oh, right, yeah. And bring the knees in and out.
Yeah. So
Yeah.
it's like a sort of resistance thing you push.
Yeah, definitely. So if you do the 4-sign technique, then strengthen the opposite, so adduction, and then strengthen abduction. How would you strengthen abduction? So Naomi's obviously taught one where you lie on the side, you lift the top leg. What else could you do to strengthen your hip abductors?
You can do like bridges.
What kind of bridges? There's a whole plethora of bridge options, Jack.
Lie on your side and like lift up that way.
Yep, perfect. Really nice body weight, no equipment needed, abductor exercise. So lie on the side and then literally you just lift up using the legs. So you're working the abductors. Anything different?
You could do like a, what do you call it, like a duck walk to the side
Yeah, perfect.
with the resistance band on.
Yeah, you've got a resistance band around the legs and you can step or squat with the band around the knees, and that's going to work and emphasize the abductors. So the big question is, why are we doing this? Why are we breaking down and isolating movement in this way? And that's what I want to just go through now with you is if your clients are squatting or lunging or doing the big compound movements, and there's a part of their pelvis function that isn't contributing to that movement, the movement can appear problematic, stiff, uncomfortable, weird, the knees drop in, that kind of stuff you see. If we systematically, remember the pyramid, test the pelvis, do the 4-sign, get the pelvis moving well, release muscles like piriformis, which is an abductor, then strengthen the antagonist, which takes advantage of this opposition law, reciprocal inhibition, which enables you to strengthen the joint strength ratios of your client's hip. And then you strengthen the abductors. So it's like a system of approach, if you like, to program design. And then everything else you're learning on your personal trainer course, you layer on top. So this is that base layer of preparation. Get them moving well, strengthen the opposite muscle, and then strengthen the agonist muscle. And if you follow those protocols, that's way more advanced than a regular PT. Regular PT is about gross movements, which is what you're studying now. What I'm adding in is a more advanced way of analysis, understanding the biomechanics of joint strength ratios, which we don't tend to study on our personal training courses. This is why Lee wanted me to speak to you guys, is to give you that little bit of extra nugget of information. Does that raise any questions? Is that confusing? Does that make sense?
Can I ask a question?
Yep.
See, you know the way you were saying there, say somebody came to you and they had an actual issue and you knew about it. Do you ever use, I know with my body massage, we used to use like a person profile, you know, when it's in market, you know, like, so then you could, you know, if they were standing, you know, I can't mind the name of the sheet.
So it's usually in, so just to, let me know if this is what you mean, Naomi.
Yeah. And then you would have marked it. Would you recommend somebody, would you use that if you knew somebody was coming in with an issue?
Yeah.
Okay.
So this is the one we teach. So we have a Biomechanics Coach diploma, which includes the level 4 low back pain. So if this little workshop really interests you and you want to learn all of these tests, I'm going to go through just a couple with you. There are a total of about, I think we teach about 43 physical assessments: pelvis, spine, shoulder, knees, feet, muscles, bones, nerves. And then I would use this. So I've got a client coming tomorrow. So I've just prepared a load of paperwork. But that's what you mean, isn't it, Naomi?
Yeah, and then you would just mark issues where
Yeah.
you would see them, yeah.
So on here is the, see, so there, where is it? There's the 4 sign there. So I would mark if he's got a problem. And then this is for me to explain to the client, this area of your body is where we've got some work to do. We're going to do that first before we start doing your running, strength training, weight loss program, that we need to get you moving well here first. So that would be a tool I would use. Yes, Naomi. And I think personal trainers, we generally we're not usually given this kind of stuff until we're in a more advanced course. And really it should be part of our base training, which is why, as I say, Lee's invited me in to speak to you guys. And then, yes, Betty, I'm just literally doing some blogs and videos around pelvis, spine, shoulder, knees, feet, but pelvis at the minute, around the bones and then the muscles of the pelvis. Are you familiar with the 3 glutes?
Like the medial, the gluteus maximus, and can't remember.
That's all right. One thing I want to instill in you guys, and to Betty as well for having a go, don't be afraid to say, I don't know.
Yeah.
And I think our industry is far too judgmental, which can stunt learning. And so what I want to say to you is, in my classroom, no question is a stupid one. And I encourage people to say, I would rather you said, I have no idea, can you tell me, than kind of like wing it or feel uncomfortable and not, you know, feel like, because I want to help you find ways to remember anatomy. So you've got 3 glutes. Can anybody remember? So you've got glute max, glute medius, and
Glute minimus.
Glute minimus. So max, medius, minimus. What would those words make you think is the difference between those muscles?
Big, small, and
Yeah, exactly. Glute maximus is the big muscle on the back of the hip. And what's that prime movement that it produces?
hip extension.
Hip extension. So glute max on the back will extend the hip behind. That's your squatter, that's your deadlifter, that's the big muscle, that's your butte, that's your hot pant muscle, whatever you want to call it. And then you've got glute medius and minimus. So medius is bigger than minimus. And what do medius and minimus do? Do you know where they are?
Yeah.
They stabilize.
Okay, let's go with they do, hopefully. But if they were to shorten, what movement would they produce?
Abduction.
They would. They both produce abduction. Do you know what else they might contribute to? No
External
panic.
rotation.
Actual extension? No.
External
Flexion
rotation.
They
extension.
do actually contribute to flexion and extension. So weirdly, more rotation was what I was after. But if you think, my favorite question in anatomy is, so what? So what? How does that help me help a client? Right? So, and I'm coming to your question, Betty, I'm not ignoring it, but just to help, when you have a question, and you should know your anatomy, but I guarantee you, when you start PTing, you'll forget it all. guarantee you, because your client is not interested in their pectineus or their quadratus lumboris. So you won't have the opportunity to practice it unless you actively practice it with your peers. And then as you forget your anatomy, when you're watching a client, they don't move very well, you lose confidence because you think, what muscle is it? What muscle's going wrong? And it's not really helpful to you. So what I'm trying to show you is a simplification of movement. If you remember flexion, extension, abduction and rotation, sagittal, frontal and transverse, you're good, because that's the movements that you need to understand. I may be stepping on toes there. You do need to remember your anatomy as well. But in answer to Betty's question, would glute work be part of the programming of the foresign antagonist agonist work? Now that you've heard the anatomy of the three glutes, would they play into adduction and abduction, or one or the other? Yeah. So if you were going to be working the abductors, that is glute medius and minimus. They are the prime abductors of the hip. Glute maximus is an extensor of the hip. So depending on the exercise you're using I can't remember who it was who mentioned it, the glute maximus is going to assist with stabilizing the pelvis whilst you ab or adduct or do your side bridging, so that your abductors can produce a solid movement. So yes, they will be, but the three glutes will be doing different things. Does that make sense, Betty?
Yeah.
Yes. How you doing? Do you want a little breather? Okay, so little screen break there, and let me know if anything we've covered so far raises any questions. We've gone over what biomechanics is, why it's important to us as personal trainers to understand a little bit about why we need to understand what's going on inside our client's body, how that affects the way we're coaching them or the way they're moving. We looked at a pelvis function test, the foresign, and we looked at the pelvis function exercise, which is also the foresign, known as a muscle energy technique, using the 20% effort, hold for 20 seconds to enable us to improve their pelvic function. And then we've talked about how we can then layer on top of that program design that takes advantage of the law of reciprocal inhibition, which means that we strengthen the opposite side of the one we've released, we strengthen the opposite side, and then we strengthen the side. And it's this systematic approach before we then get them to do the compound moves. So it's really that isolation training to improve the ratio of strength. Now, an interesting statistic for you is that your ratio of strength comparison between your ab and adductors should be 1-to-1. So what that means is your abductors and adductors should have the same level of strength for good pelvic function. So a subjective simple test for that is the hip abductor machine. You go on it, you put the same weight on it, you do the same reps and sets in either direction. There's a good chance your adductors won't be able to perform in the same way your abductors do. And this is again indicative of our lifestyle, and our role within that is to improve function and performance. So a lot of training is very sagittal. So you remember this plane of motion. And I always remember sagittal because of Sagittarius, which is, that's the horse, right? The half man, half horse. Am I right in that? Anyone Sagittarius? Is Sagittarius...
No, it's a man with a bow.
Say again?
Just a man with a bow.
But isn't he half a horse?
Don't think so.
With a bow?
Not sure he is, to be honest.
Okay.
I'd be surprised.
My mind muscle connection things like off then. but the sagittal direct, I always remember, the way I remember it is.
Oh no, you're right, actually.
Say again?
You're right.
Oh, am I? Oh, right, okay, thank God for that.
I'm
I was gonna
Sagittarius too,
say,
and I
I
didn't
wasn't
know
going
that.
to tell anyone. Sorry.
I'm a Sagittarius too, and I didn't actually know that.
Right, so Sagittarius, if you imagine sagittal plane, my memory connection is, if you imagine the horse portion, the horse's reins are in that direction. And that's how I remember sagittal. And then I remember frontal plane, which is this way, side to side, like you're presenting your front. So by putting your arms out to the side. And then obviously transverse, people seem to remember that one. But I remember it took me ages to work out sagittal, frontal, because I used to say frontal, but no, frontal. So it's just little ways that I used to remember things. But what I was getting to was a lot of exercise, lunging, squatting, pushing, pulling is very sagittal plane strength based. And what I want you to really consider is to be stable, like Naomi, for example, in gymnastics, you guys will fling yourself in all directions, right? So to have the stability and control when you land on one leg so that you're landing has control through the frontal plane, the ab and adduction strength work will enable you, I think, was it Matt, you talked about stabilization with using the abductors. They will be stabilizing you when your foot hits the floor, even when you're walking or running. So Kevin, with your runners, you will want to have them frontal plane strong. Does that make sense?
Yeah.
Anyone? So if we get our clients strong in landing by using, so we've got lunges, we can do lunges, that's great. We can do squats. These are very sagittal plane strengthening moves. But we really want the foot landing to be strong so that the leg or the knee doesn't wobble this way. So we need the ab and adductors to be strong when the foot hits the floor or they are lunging or squatting or whatever they're doing to stabilize as they do those movements. So I hope that all makes sense. But that ties in nicely with the 4-sign test, 4-sign exercise, antagonist strength work, agonist strength work in the frontal plane before squatting. That's why we would do it. So if you can always justify why you're doing certain things as a personal trainer, then nobody can argue it. It would be logical if you've got a reason behind it, which is the importance, an important aspect of what you're doing when you're working with a client. So any initial questions coming back in as we go into spine biomechanics?
I have a quick question.
Yeah.
If someone, like, still in the sagittal plane, if someone is doing like a forward lunge and they find their knee went in slightly with a lunge, but with a squat they were okay, like, what I often think, like, when I'm doing a forward lunge, sometimes I'm not in a direct straight line and I'm really conscious of that. Would that be like a hip mobility thing?
Great question. Now, what you will learn in my classroom is I try not to answer questions. I say, what do you think? Let's make this simple for you, Betty, right? Because it's a really good question. What's the difference between a squat and a lunge? Because they're both sagittal. They both involve, excuse me, flexion and extension. Excuse me. So what's the primary difference between a squat and a lunge? Anyone?
The squat's much more stable because the center of gravity is different. The lunge is a more sort of difficult movement because of the strain and the stretch you're putting on the muscle.
Okay. Why is that? What's the difference mechanically? I may not be asking the best question here.
Is that a
You're-
lunge? You step
Go ahead,
forward?
Matt?
Sorry, a lunge is stepping forward, whereas a squat, you're basically already in a standing position, and then you
Okay.
squat down from there.
Let me make it clearer because I haven't made it clear. Let me give you an example. And Betty, correct me if I'm wrong. So the squat is here, down and up.
Yeah.
Yeah. And then the lunge is here, down and up.
Yeah.
That's what I had in my head. Is that what you meant, Betty?
Yeah, so like so not a static lunge going up and down, like a forward lunge and then back.
So there's even more differences, right? Okay, good.
That's
So the foot position, would it be the main problem there? The foot position of the back foot?
So what Betty's asking, just to clarify so that then I can help you answer the questions yourselves, to be clear. In a squat, the knees are fine, but in a forward dynamic lunge, i.e. step back, is that right, Betty?
Yeah.
Right, the knees cave in.
just slightly.
Number one, they're two totally different movements. Yeah, they're both flexion and extension of the knee, hip, and ankle, but everything else is totally different. So the things that are different are what? If you think about side to side, one compared to the other. So one is symmetrical.
Yeah.
And the other one is asymmetrical. Yeah, so that's one difference.
Yeah.
The second difference is, whoever said it, I think it might have been Kevin, a squat, your feet aren't moving, you're going down and up. So you're more stable. Whereas if you're stepping, so you're taking a foot off the floor, meaning that you are balancing on one leg to then land on one foot, and then you come back. Whereas a squat, you've got 2 feet on the floor, right?
Yeah.
So that's another difference. And then if you think about your base of support, the squat, it might depend on how wide your feet are, but the lunge, actually, there may be a narrower base of support because the legs are on a line rather than out to the side. So there's quite a few things that make the two moves different that might result in you having a different response at the knee. But in application, so they're not really they're not a direct comparison is the first point for those reasons. So the question is, what could be done about the lunge? I think that's where you're getting to. Is that right, Betty?
Yeah.
Correct me if I'm wrong. Right, okay. So what could we do to Betty's lunge? And is it the front knees coming in?
Just slightly, just ever so slightly.
Does it hurt?
No.
But it's only a tiny bit.
Yeah, I have really long femurs, so
Right.
my squat's quite wide, so I've had to sort of really push into learning that because it was really hard. My knees did cave in with a squat quite a lot.
Okay.
They're not anymore. But yeah, I just noticed with the lunges because I don't do them very often, but I just noticed when I did, it might be a balance thing. I don't know.
So you don't do lunges as often as squats either?
Yeah.
Right. So we're collecting data about the client. Yeah. If you squat more than you lunge, you're going to squat better than you lunge because your proprioception's been practicing it. Squats are symmetrical and you've got a wide base of support and you're just going up and down. So it's an easier move anyway. A lunge is a more complex move neuromuscularly. And what that means is your brain has to do more to control the lunge. Even if biomechanically you were really great, your brain has to do more because you're asymmetrical, you're standing on one leg, you're taking your foot off the floor, you're on a narrow base of support, and you don't do that move as often. So those would be all things coming into play. So everybody else, what could we do if we felt that Betty's lunge was detrimental? List of things that we could do.
Regress it slightly by placing the foot like on a plyo box or something like that.
Placing the foot on a plyo box.
Yeah, like the rear foot, and then just sort of doing, doing a lunge type movement from there.
So you've got the back foot elevated.
Yeah.
Yeah. And then the front foot is static.
Yeah. And you're just, well, no, so you're just sort of then moving at the knee on the front foot, if that makes sense.
You just go up and down.
Yeah.
Right. So you're no longer stepping and stepping back.
Yeah.
Right. Okay. So again, it's a completely different move again. It may be harder because you're loading the front leg more by elevating the back leg. So
okay.
I would go with the idea of keeping it static first and just go down and up first. And then you could load the front leg more by having the back leg elevated. So that would be one way. What else could we do? What have I been teaching you?
You can
You're not giver-
strengthen. Oh, go ahead.
No, go on ahead.
Come on, Jack.
No. I insist.
Go,
Go on,
Jack,
Naomi.
you go. Do you not? For my older clients, I would use a wall. So you like, in case it was a balance issue, you like stepping out in front. So like using the leading leg, running up the walls, then a push. They have the push against. They can push against something sturdy to keep the knee out.
Could do. It's much simpler than all of this, guys. So all of this, yes, I hear you. And that would be the standard response. But even simpler than that, what have I just taught you?
Strengthen the individual muscles that are going to be in.
Do a pelvic function test, strengthen the frontal plane stabilizers before you then go and do the lunge again. Exactly right, Jack. And then to listen to what Naomi's saying and pick up on that. If balance was a little bit of an issue, and I wouldn't know until I watched you, Betty, if I felt that balance was an issue, we might have you not holding on to him, holding on to something, hold on to the wall, and then you've got more base, you've got more neuromuscular feedback. Yeah. So I'd test your pelvis, I'd do what Jack said and stabilize, use your ab and adductor stabilizers. Then I'd get you static, like, was it Kevin who said about the static lunge? And then we'd progress you that way. Because at that point, we don't know. They're two different moves. So your comparison isn't really enough information. Does that help?
Yeah, no, that's good. Yeah.
Brilliant. Well done, guys. So that's what you do. That's what you ideally want to be doing as a PT is, right, if Betty was your client, she comes in and says, when I squat this and when I lunge this. And then what you've done is you've worked out, right, okay, we'll test the pelvis, we'll get the stabilizers working, the ab and adductors, then we'll regress the lunge and we'll progress. And we might then focus on a lunge pattern and then start to add in and then get you back to where you want to be. Good. Lee's trained you well. He says hello, by the way. He said bonjour. He sent me a message to tell you. Right, okay. Who would like to have a little study of spine biomechanics? Anyone?
I'll do it again. I don't mind.
Brilliant. I'm glad. Thank you for that. I really miss the classroom. I've got no problem doing these online things, but I love getting in a classroom with a skelly, so forgive me, keeping you all talking. Spine biomechanics. So the left-hand image is a lateral view of two vertebrae in the lumbar spine by the look of it. And what you can see is the blue portion is the disc. And then the right-hand image is like a view overhead, as if you've been sliced down the middle. And the bottom of that blue kind of section is the front of the spine. And the bit at the back, that yellow kind of horns, is your sciatic nerve. And then off at the top there is the spinous processes. And the reason I'm showing you this is it's understanding how, it says at the top, facet joint integrity. So where your two vertebrae meet, you see in the middle there on that left-hand image, there's a joint. Can you see how they sit together? So each vertebrae will sit on top of the one below, and they are kind of coming together via a facet joint. And a facet joint has a really important job in your spine. Now, it is just a joint. It's just where two bones meet. But the job of a facet joint is to limit how far your spine will bend, all right? Now, your spine should, in every direction, give you a nice, smooth, curved shape, ideally, without any discomfort, and you should be able to achieve certain ranges. So we're going to go through some spine mobility tests. But that facet joint is deliberately in place to protect the discs and the nerves and the spinal cord. So in terms of our level of expectation as to what a client can do, understanding that there are certain limits, and that's deliberate to protect the soft tissues on the inside. So who have we got out there? Let's have a look, because I'm going to get practical again. Who can we see? Let's put you onto gallery view. Okay, Jack. Everybody look at Jack. Ready? Jack, stand up.
Okay.
Sit down. Now sit down, sit down, sit down, sit down. Sit down.
All right. Okay.
Ready? Let's do it again. Everybody look at Jack. Wait. Stand up. And sit down. Brilliant. Perfectly performed. So my question to you guys is, what is the first thing Jack did?
Leant forward.
Before he leant forwards.
He
Planted
thought
his
about what
feet.
you were doing to
Yes,
process the
Naomi,
movement.
he did think about it. And then what did he do?
Planted his feet and took a deep breath.
Before that, maybe?
He sent the nerves, this responders.
Yeah, exactly that. You got it, Naomi. So when we watch a client move, what we think about is generally what we see. Yeah. So, which is why instinctively, when I say what's the first thing you did, you would say lean forwards. But before that, exactly as Naomi's highlighted, my voice produced a vibration through the speaker, went to his ear, his brain acknowledged that. This is all happening in split seconds. The neural pathway down to the deep, the multifidus, the longissimus, all those rotatorius, tiny muscles around Jack's spine will have engaged enough so that when he goes to lean forwards, his spine doesn't just fall. Yeah. But you don't consciously, Jack didn't sort of consciously go, right, okay, multifidus are on, tick, rotatorius are on, tick, the erectors are now on, tick, now I'm going to lean forwards. It all happens without us thinking about it. And there are certain things that go on within the body that if there is a dysfunction, if something's not moving that well, that means that other parts of the body are going to have to help you do that movement. So there's intrinsic compensation. Does that make sense? And we're going to talk about that when we get more into the core bit. But before that, we're going to run through some spine mobility tests. So again, push yourselves back. Let's get dynamic so that we're not just sat statically looking at screens. Let me bring my screen down a little bit. So having your camera around about knee level. Okay, and then if you can, go side on to the camera. Only if you want me to see you. Now, we're going to test your spine's ability for flexion first. So we're going to separate each movement of the spine. So fists on thighs. And then what I want you to do is just relax, chin down, and then you're going to roll forwards before you go. Hang on. If anything is uncomfortable, please sit up, do not continue, all right? From here, slump, chin down, roll forwards, aiming your shoulders towards your thumbs, and then roll back up. So, and then you're going to tell me, I can see a few of you. Okay, number one question, was it uncomfortable for anyone? No, fine, fine. Betty,
Towards
how
the
did you
end of
feel?
the movement.
Who was that, Kevin?
Yeah.
How did yours feel?
Just got tight in the upper back towards the very
Bit
end.
tight, yeah. Donna, how was yours?
No, I was okay.
Okay, perfect. Question 2. Did your shoulder touch your thumb? Don't force it.
Nope.
Not sure. So Jack's thinking he might not have his shoulder on his thumb. Betty?
Well, my tummy's in the way, kind of.
We'll talk about that in a moment. That's all right. Donna?
Yeah, it was okay. Yeah, mine's
Okay,
fine.
cool. Matt? Woo. Naomi, are you having a go in there? Yeah.
Hey, you can't hear me. Sorry, I'm shouting away there. And you
Did
couldn't
you
hear
get
me.
there? Was
Yeah.
it uncomfortable?
No, it was fine.
Right. So when we're testing a client, what we're trying to understand through this test is, and you need to have the seat at 90. So if your legs are up here, that's kind of a cheat, right? Or if your legs are down here, then that's going to make it harder. So you really want the thighs parallel to the floor, fists on thighs. Now what we need to happen is we need to see a rounding of the spine. So it's no good if you're here. Yeah. So we need to get them round, fists on thighs, shoulders towards thumbs, and technically you should be able to touch your thumb with your shoulder without forcing it and without any pain.
Oh yeah, I was doing it wrong. I can get it now.
Oh right, who was doing it wrong? Betty.
I don't know where I had my hands, but yeah, I was able to touch my shoulders, yeah.
Perfect, brilliant. So it's one that people more commonly are able to achieve, but it's another test you can add really easily to a client. It's safe. If they're stiff or it's uncomfortable, we're going to do some mobility work later on. Second test is extension. So on this one, same angle, same seat, but this time from here, what we're looking for is, can they produce a smooth curve without any discomfort? Yeah, so you're doing the opposite now. So I can't really see many of you, so I'm going to have to trust you. If it hurts, Betty looks good. So if you sit off your chair, sit away from the back of your chair, stick it out, Donna, that's it. So keep your body over your hips. So yeah, a little bit stiff there, Donna. I might want you to do the exercise for this.
Oh, no.
Let's have a look. Matt's got a heavy sweater on, so I'm not quite sure there, Matt. Can't quite see. Jack, no idea. You look like you're moving a lot, but I can't see. Betty, you look great. Actually, that looks quite good, Matt. So again, if it's uncomfortable, then they probably need to help mobilize it. Or if they're quite flat, or they look like they're not actually going anywhere. So for example, they start here and then they kind of go like that, but nothing happens. I'm exaggerating, but that's a little bit like yours, Donna. So you move from higher up here, but the bottom bit is almost staying flat. And I can't see very well, so I may be wrong, but it looks like you're a little bit stiff at the bottom. Yeah, a little bit. You really want a nice, smooth C shape. Mine's slightly stiff down the bottom here, but then you've got that curve coming up. So again, does their spine have the capacity for extension? Yes or no? Is it uncomfortable? Yes or no? And if anything causes pain, we probably want to consider, are they doing it too much? Is there something we need to refer them for? Or if it's like Kevin was saying, where it's just stiff, they're probably going to benefit from the exercise. Yeah. Third one is facing to the front, and we're going to use the, this is called a medial epicondyle. That's basically the inside of your elbow bone. Yeah, so the bony bit on the inside here. Upright, as if you're between two planes of glass, front and back. And then from here, keeping the bottom or the hips on the seat, you're going to side bend as far as you can one way without your hips coming up. Don't let the hips lift, keep the hips down. And you're going to see where that bone comes to. And then when you come back up, you do a comparison to the other side. Oh, you see me, that side's stiffer. Has anyone got a bit of asymmetry going on? Is
One
it
side's
stiffer one
tighter.
way? Donna?
Yeah, one side's tighter.
Yeah. Jack?
I think it's pretty symmetrical on both sides.
Okay. Betty is
Pretty
flopping around all over the place, looking good. Keep your bottom seat, your ischium, your itchy bum, keep your ischium planted on the seat. Matt, how do you feel in either side?
Fine. I think I'm pretty much symmetrical.
Good, good. And again, it's about not assuming you're going to be getting a result where, oh, right, we need to do something. Some people move well in some directions and not so well in others. So that's your side bend test. Now, ideally, your elbow bone should reach the top of your seat symmetrically from side to side. So what you could do with a client, and what I usually do, is with their permission, I take my phone and I photograph at knee level. So I get to where I can see exactly where the elbows are, and I can do a comparison where I put one photo in one of those apps, put the, to the right side, and then I do to the left side, put it in the other side. So I can compare the symmetry. And then that looks quite impressive to the client when you're showing, you must ask their permission or cut the head off the photo, by the way. Make sense?
Mhm.
Next one. So the last one, super simple. Let me move him back. So what's the movement for the spine we haven't yet done? We've done flexion, extension, lateral flexion,
Rotation.
rotation. Now, rotation is harder because more things can give you a cheat. So what I want you to do is make sure your knees don't slide. Yeah, we don't want this happening. So knees fixed, and then you're going to put your fingertips on top of your shoulders there, elbows in a straight line, and then I want you to see if you can squeeze your shoulder blades together. Keep your shoulder blades together and then turn slowly one way. Now, the minute your shoulder blades start to move or your knees slide, that's you stop and come back, relax, and then we do a comparison going the other way. And I can go further that way than I can to the right. So that way I find harder. And again, you're doing a comparison. So make sure the elbows are up in a straight line, and then you squeeze your shoulder blades back, and then you're watching or feeling. See, I won't turn that way, but I can turn much further that way. Make sense? How'd you get on that one, Jack? Symmetrical?
Yeah, pretty symmetrical on that one, yeah.
Brilliant. Matt?
Yeah, I think so.
Brilliant. Now, another way you can make this test more objective, if you like, is with a pole.
Oh,
And then you can put the arm over the pole, and you've got more of a measurement then. So I go that way, I don't go that way. And you can almost kind of visualize how far the pole is turning. So you've almost got like a measurement there. Any questions on that? So what do we do about each of those? So if somebody had difficulty with spine flexion, what would spine flexion mobility look like in terms of an exercise?
Cat cow from like yoga movement.
Yeah.
Could you do a back extension?
Who? Hang on, let me pull you up. Who's speaking? Let's have a look. Who's that? Kevin?
That was me.
Oh, Matt, sorry. What move, what yoga move was it?
Oh, sorry, that was Kevin who said the yoga move.
Oh, so Matt, what was your move to improve spine flexion?
A back extension.
So you go that way?
Yeah.
Well, if if flexion is the problem,
Oh, right. Yes.
yeah, so that what you're talking about might be good for the extension mobility that's limited. So if Donna's spine, if we felt that hers wasn't good going that way,
Yeah.
then we could use your one. What about for flexion, guys? Help Matt out here. What was the yoga one? Somebody said.
A cat cow.
Aye.
Sorry, I don't know who's speaking. I can't because I
Kevin.
can't see. Kevin.
Yeah.
Yeah. What was the yoga move?
A cat cow.
A cat cow. Right. Are you guys familiar with a cat cow?
Yeah.
Are you all familiar with a cat cow? I'll help you out, Matt. Don't worry. Kevin, do you want to demo it, or do you want me to demo it?
Camera's not working. It's showing me like in the dark, so you'll have to do it.
Okay. So a cat cow, which is a yoga move, or correct me if I'm wrong, Kevin, on all fours. Yeah, and then you go into flexion for a cat and extension for a cow.
Yeah.
So could you do both, or would you do one or the other for flexion?
For flexion, you'd be more focusing on the cat.
Yeah, exactly. So you'd be more focused on going this way if your PT client was struggling with flexion. Yeah. Another alternative could be what we call knee to chest, where you lace the fingers over the knee, push away with the leg, and then draw the shoulder blades, the front of the shoulder up, lie down, switch, push away with the leg. So it's not an abdominal crunch. I'm using my legs and my arms to round the spine. Let me show you side on. So here I can really kind of encourage flexion. You could do both legs, push away, round the spine. And of course, you've got your cat position here. But then obviously Kevin's suggestion could fall into the extension portion. So if somebody was struggling with extension, then you've got the cow portion of cat cow. Yeah, anything else for extension?
Call them dead bugs. You know where it's one leg out and one arm out.
What position are you in?
On all fours, and then you stick one arm out and then the opposite leg out.
Yeah.
Is that a dead bug? Is that what you call that?
I think dead bugs is on the back, isn't it?
That's a bird
Oh,
dog.
yeah.
So this one's a bird dog, is it?
Yeah.
So remember what we're trying to achieve is improved mobility rather than strength just now. So we're trying to encourage movement as in joint mobility.
So you could do like lying over like a pregnancy ball type thing and just sort of decompressing the spine nearly.
Let me, so what do you mean? Foam roller?
Yeah. Well, I was thinking more like a pregnancy ball, like the big inflatable ball, but
Oh,
yeah.
the big stability balls.
Yeah. And
Right.
like lying over it
Is
backwards.
that going to encourage mobility of a joint?
No, I suppose not.
You might be lying and lengthening the extensors, but to encourage mobility, for example, ideally, you want to do extension. So you would actually get them to extend the spine and encourage movement. So mobility, which would be your cat-cow, or the cow of cat-cow, or then pelvic tilt, so that you're moving that joint. You're trying to help the joint move better. Does that make sense?
Yeah.
And then, so what about side bend? What could you do to improve side flexion mobility? A really easy one, this one, isn't it?
Just stretching
Yeah.
overhead to the side. Like
Yeah,
that.
you do the test, wouldn't you? The test would be the exercise as well. You could just do side bends. So what about rotation?
This. The upper twist, no?
Yeah, do you want to describe it, demo it, or talk me into it?
Like if you're standing, I do mine usually standing, then feet shoulder width apart. And then you can keep your arms at your side or cross your hands over in your chest. And then it's just keeping your hips facing forward and then rotating to the left and the right.
Here.
And then
Yeah.
I usually hold.
Right. One of the things to be careful of is clients can often, let me show you this way. Clients might, is my spine moving here?
No.
No, you have to do
Yeah.
everything.
So one of the things, so you were right, if they keep the hips still and turn here, then yes. But what clients do is cheat, because if their spine is stiff, not all of them, but sometimes, if their spine is stiff, they might do this, they might misinterpret it. So again, we could use the test as the exercise, but I would strongly recommend fixing the hips so they don't move, and then you could use literally the test again, and having the arms in or you know, here, gives them that feeling of movement and helps them to get the spine moving again. But even breaking it back down onto the floor, and we can break down lower body, upper body rotation. You've got your knee rolls for lumbar rotation, and then you've got your shoulder rolls, which makes the movement very focused on the part of the spine that's not moving well, and it kind of removes the ability for the client to cheat, even though when I say cheat, they don't realise they're cheating, you know what I mean? But because the body is not moving well, the body is cheating for them, and they don't realise they're not actually moving the bit we're trying to get moving. Does that all ring true when you think about clients' movement? Right, brilliant. So let me just bring, it's all right, flipping between these views. And then what we're going to go into, time, we're right on time. So we had Jack do the stand up, sit down to understand there is a chain reaction when we move. And then we started looking at spine mobility. So the flexion test, can they, with the hips at 90, show us that their spine will flex without pain, and do their shoulders reach their thumbs? Spinal extension test, do they get a nice smooth curve without any discomfort? Lateral flexion, have they got symmetry? Do the elbow bones reach the seat height? And then rotation, have they got symmetry going right to left? And then the exercises, we can use all of the ones we've talked about. And what we're trying to do is limit other things happening, and what they think is mobilizing them actually is coming from another part of the body, which is why we specify, keep the arms still, keep the hips still, make sure the movement is good through the rest of the body. Does that make sense? So let's talk about core stability for this last sort of phase and section. And if you think about what I'm presenting to you, we've done the pelvis, got the spine mobile. We're now coming into, if you like, that second layer of the pyramid, where we're going to consider stabilizing and giving the client some control over their body. So core stability, if you were to put a definition on it, and if you Google it, base of support, foundation, you might have people talk about specific muscles. But if you were to sort of really take a simple definition, there's a guy called Mel Sith who wrote a book. It's a brain dump of a book, maybe a bit early yet. But if you are a book nerd, this guy is, it's mind-blowing. I probably haven't read all of this one yet. It's just so technical. But if you're a geek and you like the strength principles, that might be one for you. Super Training, Mel Sith. Super Training, Mel Sith. So he gives a definition for stabilizing a body segment. And we just changed body segment for the spine because we thought it was a good definition. Muscles stabilizing or supporting the spine statically or dynamically, while other muscles carry out a movement involving other joints. And we felt it was quite a good kind of overview of what core stability is. And then a visual representation of it going from left to right. If that yellow ball was your spine and you generated force, it would fall off very easily. But as you come along to the most stable on the right-hand side, it's almost like a vase. If you imagine that in 3D, the sides of the vase around the spine being the muscles, it's going to be the most stable. So there's been research taken out of context that talks about the TVA and multifidus are the key core muscles, which is not true. They are important, but every single muscle within your client's bodies is important in its own job role. No one muscle being more important than another. And we're going to look at a few now and explore what I mean by that. So going through the layers, if you like, of trunk. The transversospinalis group is that very deep proprioceptive group that Jack switched on without thinking about it before he came forwards in his seat to stand up when I asked him. So they applied a certain amount of tone around the spine vertebrae so that when he did lean forwards, his erector spinae group had the opportunity to then continue that stabilization so his hip extensors could drive him out of the seat. So there's the erect spinae group. Are you familiar with QL, quadratus lumborum? Have you looked at that muscle yet? Anyone? Have you looked at QL yet? Quadratus lumborum? Just say yes or no. Okay. So the QL muscle is a tiny muscle in, oh, I need, hang on, let me bring the scale in. And I want to talk about this one because it's another important one. And if you haven't done your exam yet, I'm hoping this might help along with your exam. So quadratus lumborum, quadratus being square, and then into the lumbar area, lumborum. And the quadratus lumborum comes from your 12th rib here into the ilium here, and then it feeds into the transverse processes, which is these bits of the lumbar spine. So it basically sits in there. So you can see how the one on this side would bend you that way, and the one on the other side would bend you that way. So it's a lateral flexor of the spine. So a bit like, I think it was Matt was talking about the muscles in the hip are stabilizers. We talked about when your foot hits the floor, they stop you from swinging side to side. And the QL is similar in the spine. So from the bottom rib to the top of the ilium, it assists with the gait cycle. So as your hip lifts, that's the QL muscle is lifting the hip. It's a lateral flexor and it lifts the hip when you walk, but it will stabilize you in the frontal plane. Does that make sense? So it is a key muscle. And then would you have described your lats as a core muscle? Would you describe the lats as a core muscle? Because they do attach between your pelvis and your shoulder. So if you imagine being on all fours doing the, what do you call it, the bird dog or the fire hydrant, if your lats are not engaged, you're not going to be stable through the trunk. So our clients often think of their core as the front of the body. And what we need to do is try and educate them that it's actually the whole of the body, the back's included, the side as well. And each of these muscle groups has different jobs. So this is, again, comes back to Jack's movement when I asked him to stand up. Those deep pore mechanical movers, so what that means is they're not big levers, they haven't got big levers, they're tiny little muscles that give proprioceptive information to segmentally stabilize the vertebrae, so that when he leans forwards, the erectors have an opportunity to engage, and they're the next layer, so that then the rest of the movement is produced with the bigger muscles. As we come down, QL, quadratus lumborum, is a frontal plane stabilizer, so it stabilizes in this plane of motion. And so it works with the glute min and med, or the TFL on the side of the hips, to stabilize you as you walk forwards. And then the lats, obviously, linking the pelvis and the shoulders together. Other core muscles, I'm sure you're familiar with: TVA, internal, external obliques, and rectus abdominis. And the different directions of the fibers of your six pack is deliberate to give you, this stabilization in lots of directions. So people always think of the rectus abdominis as a spine flexor, which it is. And if you do your exam and it asks you, then they do flex the spine. But their primary job role is a co-contractor with the spine extensors or thoracolumbar fascia, so that they limit extension and they hold you upright so that when you move, because while they do produce flexion, that's not their only job. Otherwise, they would look like a hamstring or a bicep. The reason you've got these pockets of fibers and then you've got your internal, external obliques crossing through is because when you move, you're moving in all sorts of directions at once. The hip flexors, we may not actually think of as a core muscle, but they do attach to the lumbar spine. They attach in, as you can see from that image, into the same landmark as quadratus lumborum. So those spinous processes on the side of your lumbar spine, both QL, quadratus lumborum, and the psoas attach to that area. So your hip flexor problem could limit what the extensors can do because they're antagonists to each other. So the front of the hip or the hip flexors attaching to the spine at the front could be problematic for the spine extensors at the back. Okay, how are you feeling, guys? I need to look how you're feeling, because if you're getting fatigued with this, how are you feeling so far? Good. Can I do a task session with you? So I'm going to show you a movement and we're going to talk about agonists, antagonists. Have you talked about synergists yet? Mm-hmm. Yeah? Have you talked about everything else as a synergist, or that there are two types of synergists?
I think two types, but I can't remember what they are. Brilliant,
brilliant. So what I'll do is I'll give you the definitions that I would use, and you can tell me if it sits with what you've been told already. And if not, it may just be that I clarify. It will be the same. It may just be a different use of language. So when it comes to this, this is my favorite session that we teach on our whole diploma. And the reason for that is the simplification of movement. So I want you to forget muscles completely. Forget all the muscles. I just want you to focus on movements, all right? And I'll explain what I mean. So I'm going to give you the first one, and then I'll ask you on the second one. So my little links man there is doing a movement. Yep. And the first question I ask of you is, what joint is moving? Anyone just shout the answer?
Shoulder.
Perfect. So if the shoulder is moving, what action are you seeing it move into? What's the prime movement?
Abduction.
Perfect. So the prime mover group is the shoulder abductors. Yeah. So rather than trying to work out, is it the medial delts? Is it the levator scap? Rather than that, it's just the shoulder abductors. It definitely is, because you're doing shoulder abduction. Yeah. And I'm doing this deliberately to try and help you out. So the antagonists to shoulder abduction are what? If abduction is the prime movement, what's the antagonist movement?
Shoulder adduction.
Shoulder adduction, perfect. So the muscles that adduct the shoulder are the shoulder adductors. Makes sense so far? Perfect. So we've ticked those 2 boxes. So we've got 2 more. So what we define in synergists is you have fixators and dynamic stabilizers, and the names of them will tell you what they're doing. So if it's a fixator, it's isometric. And so when I lift a dumbbell with this arm, so do my lateral, my shoulder abduction, there are parts of my body that are contracting isometrically, so that as the arm comes up and gravity moves this way, my body doesn't tip. So what part of the body is going to be isometric so that I can lift that arm?
Core.
The core, perfect. Because otherwise I would tip over, wouldn't I? Exactly. So the spine lateral flexors on the opposite side are probably going to be working the hardest. And then the dynamic stabilizers must be moving because they're dynamic. So there's only one joint moving, which is which joint?
Shoulder.
And we've already got abductors and adductors of prime movers and antagonists. So the dynamic stabilizers must be everything else that crosses the shoulder. Does that make sense so far?
Yeah.
You're allowed to say no.
What do you mean crosses the shoulder? Like this way, or?
Let me
The back.
come back out and have a look at you. Who is that, Betty?
Me, yeah.
Yeah, say that again.
Like everything. What do you mean, like everything that crosses the
Okay.
shoulder? Like your back?
If I was to
Rear
simplify the movement, it's just this. So we're analysing the movement, yeah? It's a shoulder abduction, yeah? So the shoulder's moving, it's going into abduction, so the shoulder abductors are the prime movers, so then the adductors are the antagonists, yeah? The fixators are here, so that I don't tip over. So these must be fixators. So the dynamic synergists or the dynamic stabilizers must be in the moving joint. They must be in the shoulder. They can't be the abductors because they're the prime movers and antagonists. So everything else that crosses the shoulder, so muscles that flex, extend, and rotate will be dynamically, they'll be changing length, but they're not producing the movement. They're allowing the movement to happen through the frontal plane.
Okay.
So the muscle, any muscle that attaches to the scapula, any muscle that protracts or retracts the scapula will be a dynamic stabilizer.
So like with the bicep, be one?
If you feel that the biceps are changing length in that movement and they're not abductors or adductors, then yeah. Depends on how well you know your anatomy. The point I'm trying to help you out with, Betty, is you don't need to know the muscles when you're analysing movement. You do need to remember your anatomy for your exam, don't get me wrong. But I'm just trying to simplify the process into movement first.
Okay.
So dynamic stabilizers are anything that flex, extend, and rotate.
Okay. Or
rotate the scapula. And if we do the next one, and it might make more sense, let me see if the next one helps you. If we repeat that process one more time and see if this then helps, yeah? So there's no answers in this one. So if you imagine that that's a video, it's not, it's static. So lying on the back, nothing moves, you lift the leg up, the knee is straight, the ankle is fixed, and then you put the leg down again. So which joint is moving in that movement? It's the hip, perfect. So the prime movers, sorry, the prime movement when you lift the leg is what action at the hip?
No.
Flexion.
Flexation.
Perfect. Yes. So what are the prime mover muscle group? If it's hip flexion.
The hip flexors.
Yes. Perfect. So the antagonists to the hip flexors must be the
Hip extensors.
perfect. So what's going to be fixing you so you can lift your leg without your body flapping around?
Your core.
Perfect. And then the tricky one.
The adductors and abductors.
Yes. Nailing it. So your dynamic stabilizers can only be crossing, because they're moving, they must be crossing the hip, because that's the only joint that's moving.
Right.
So the abductors and rotators of the hip, so exactly the same as the shoulders. Does that all make sense?
So why would your quads not be part of that? Maybe I'm overthinking this. Like,
Is that, let me just come out again.
right, it's me again.
Is that Betsy? No, I love it. I like questions.
Like, why would your quads not be part of that? Because, like,
I didn't say the quads weren't part of that.
okay, right.
So what I'm deliberately doing is showing you how to analyze movement while you're maybe not confident with the muscles.
Okay.
So if you remember when you did level 2 anatomy, do you remember that?
Yeah.
Abduction, adduction, rotation. It was dead simple, wasn't it? Oh yeah, I get that. And then you forget that because you're going, oh, hang on, vastus medialis, rectus femoris, and you're trying to remember all the muscles, and you lose the ability to just simply look at movement.
Okay.
So you're probably right. And if you want to, Betty, we can bring some muscles in, but it will make it harder.
Right.
So my question then, based on Betty's question, in that lying leg lift, what role do the quads have? Was it quads? Is that what you said?
Yeah.
What role do the quads have in that movement? Are they prime movers, antagonists, fixators, dynamic stabilizers?
The rec fem would be a prime mover. Would that be
Okay.
right? Because it's a hip flexor.
I would
So
say
Kevin
quads
says
is a hip.
rectum is a prime mover. What about the other quads, Kevin?
Um,
And then you can tell the group why.
they would be synergists. Not sure.
Which synergist would they be?
Wouldn't that be a fixator?
Yeah, they would. So why would the rectus femoris muscle be a prime mover in hip flexion when
Crosses
it's a
the joint.
de-extender?
Does it not attach at the hip too, the hip joint?
It does. Good. So when you know
Yes,
your
I got it
anatomy, you got it bang on. Absolutely right, Naomi. So is this making sense, Betty?
I think so.
So what you've raised, Betty, is the reason why we're not using muscles in movement analysis, because it makes it really complex. But I'm just going to show you why.
Right.
Unless you know the exact attachments of all 4 quads and that they do different things, it makes the movement analysis difficult because you can't put the quads into one group because they do different things. So as Kevin has suggested, Kevin and Naomi have done their anatomy homework. And what you've got is on the front of your hip, do you remember your ASIS here? Anterior, superior, iliac spine. So you've got a bony prominence there. Anterior, it's on the front. Superior, it's the top one. That's the bottom one. Iliac spine. And the anterior inferior bony prominence is the one below it. And that's where rectus femoris starts. So it crosses the hip and then it comes down with the other three quads through the patellar tendon.
Right.
So it's involved in hip flexion. It's the one quad that is involved in hip flexion, and knee extension.
Right.
Because the knee is not moving, it's this end of rec fem that is the prime mover, but your 3 vastus medialis, that's the quad in the middle, vastus lateralis is the one on the outside, the lateral one, vastus intermedius, they don't cross the hip.
Okay.
So they're fixators because as you lift your leg, the knee isn't moving and they stop at the femur, at the top of the femur here.
Okay. Right.
So this is what I'm trying to help you understand is when you think in muscles, unless you know your anatomy, movement analysis, if you're thinking in muscles, it's really difficult. If you know your anatomy, then you can layer it in. What I'm trying to do is help to simplify it for you.
Right.
But then you start to add in your anatomy training. A great book, by the way. Have you got this one?
No.
Anatomy Training, Trail Guide for the Body. Brilliant book. Andrew Beale, Trail Guide for the Body. Aimed at manual therapists, but great for PTs as well to learn movement, muscles, bones, everything. Great book.
Who's that by? Sorry, say that again. Sorry.
Andrew Beale.
Thank
That's
you.
actually backwards on my video, so I don't know if you can read it. Is it the right way around where you are?
Yeah.
All right, oh good. It's backwards on mine.
Thank you.
So, so what you're helping me explain, Betty, is the exact reason why I wanted to simplify movement analysis into movement. Because the most important thing when you're with a client is that you understand movement more than muscles. And I'm not saying you don't need to know the muscles, but the movement's more important when you're with a client because that you have no idea where their pectoneus goes. It's roughly round about there. But if you have the experience of going to a cadaver lab, you will learn that 40% of people don't have a psoas minor. Some people have 5 quads, some have 6. Some people have a triple-headed bicep. So that actually means that the books are very limiting. And then when you're watching a client move, if somebody has got 6 quads, what does that mean? Does that change their movement? Well, I know that they're flexing at the hip, but I don't know which muscles it is. I know it's flexion. So you can be black and white with movement, but you can't be black and white with the muscles in the same way because we're all so different. But we move through flexion, extension, abduction, adduction, rotation. And so that I wanted to just try and explain and show you that, if that makes sense. Does that help a little bit?
Yeah.
Is that the terminology you use for synergists, guys? Is that the terminology, Kevin? Did you use fixators and dynamic stabilizers? Yeah.
Yeah, well, just fixators and stabilizers, the dynamic. I don't
Right,
remember.
okay.
Yeah.
And are the stabilizers, by definition, in your teaching, the dynamic ones?
Yeah.
Right, perfect. So it's
I
the
just
same,
remember them.
just a slight different use of language, isn't it? So
Yeah, I think they just said the fixator doesn't move, but I think hearing the dynamic stabilizer makes that more obvious. So that's a bit of an improvement there.
Yeah, fixators, dynamic stabilizers. Fixing means it's isometric. Dynamic means it's moving, but it's not the prime mover or the antagonist.
Right.
But do clarify that. Who's your tutor? Is it? I've forgotten his name.
Oh no, sorry. This was just from a previous course.
Right, okay.
Remembering that.
Right, how are we doing? Let me just run through these few minutes. How long we got? We haven't got too long. Let me just. It is slightly lecture based, this bit, but I thought this might be interesting for you. I won't spend too long on it because lecturing's dull. Myths. So some really cool myths. So the Stuart McGill book. So the one that I showed you earlier, this one, he talks about loads of the spine. The spine can take 2,400 newtons of compression before it will start to break. So things like a straight leg sit-up is 3,500 newtons. So that's more force than the force that might start to wear on our spine. So it's understanding risk. And we're not saying don't do it, we're saying understand risk. You've got gym balls in there. And a gym ball, as you guys will know, is going to destabilize your client. So if somebody is already unstable, the last thing you want to do is make them more unstable. So you want to get them stable on a static surface first before you start to challenge them with things like gym balls. The cable chop is a very popular exercise. And again, it will build up your midsection, which nobody wants a big, thick midriff. You know, we want that nice V taper. So a low load through full range or a high load through small range might be an idea. Your hyperextension machine, the one in the middle there with the lady with the grey shorts, puts 4,000 newtons of compression through the spine. That's really high. So that's a very advanced move. And that's without a plate in the front of the body. So it's just understanding, we're not saying don't do it. We're suggesting that you probably wouldn't put Ethel, you know, an old lady who just wants to go to Tesco and back on a hyperextension machine, which I'm sure you would understand. And then the Superman, you know, again, 6,000 newtons of compression, which is quite shocking when you think, well, actually, these are things you might see in classes.
Can I ask a question?
Yeah, of course you can, Betty. Go for it.
I'm really glad you've said that about the sit-ups, because we were taught that we had to do that in our level 2, like our sit-ups and spinal extensions and things. And it's one thing that I've just avoided forever. I don't do sit-ups, and I've never had any back pain. And I have so many arguments with people saying about how they have to do their sit-ups. And yeah, that was just really interesting.
I think if you always try and think that no exercise is controversial if it fits the client, the goal, and their biomechanical makeup and their injury history. Yeah. So there's no reason why. Let me try and think of Tom Daly, high dive swimmer, who needs to do a very fast pike. You know that pike position when they're coming up? He will need to flex with power and strength. A sit-up would be a great exercise to strengthen that movement for him as an athlete. Mm. Your regular PT client who maybe just wants to lose a bit of weight, has a bit of back pain, you probably wouldn't. So I would say you're right. But I think what we need to do as coaches and trainers is keep an open mind to other trainers having a justification as to why they're doing it. You have a justification why you didn't want to do it. And I would encourage you to, you don't need to defend your opinion, but in your own mind, don't think you're wrong if you have a reason why. Yeah. So always question, why do I think that? And I wonder why they're doing it. Why would I not do it? And think of the mechanics of your client, think of the exercise, and think whether, is it appropriate for that client right now? A sit-up is going to be using your hip flexors, and your hip flexors attach into your lumbar spine. So if your lumbar spine is fragile or sore, a sit-up is going to really pull. And you've got two arguments. One is that could be a problem, and two is, well, that would strengthen it. And so that's the tricky part of being a personal trainer, is knowing when it's the right time or the right exercise for that client. So again, it's a really good point that you're raising, Betty, and I'm glad you've said it. But if that poses anybody any more thoughts, then definitely post away. But this is why I wanted to just put these statistics forwards to you. There's even the question as to whether we should do core stability work. And the way we would do it, we teach sort of 3 steps, and each of these have got like reams of exercise progressions within them. Can your client engage the core? Can you test that? Can they engage it maximally, flat on the back? And then can they control it? Before once they've gone through that, we then have, and again, I'm a massive fan, from Stuart McGill's work, we do core isometric ratio testing. So chest testing the ratio of strength around the spine, the flexors v the extensors. Do you have a right side, left side imbalance of strength in your trunk? And if you can measure that and then correct it, then they have less risk of pain and injury. And then the last phase would be your functional stability stuff, which I'm going to show you a couple of those if we should have time. So to do this, you've got this progression. So obviously the first one, flat on the back, Dead bugs, I think somebody was talking about, was it Matt talking about dead bugs? Lying on the back, literally don't move to start with, just brace and just take your client through different degrees of brace. So if I got you all to lie on your back, we'll do it sitting whilst you're sitting. So if you put your hands around your ribs and then and get yourself into neutral, like an upright posture, not too extended, and then just brace as if I was going to punch you in the stomach. And if you brace to about, let's say 50% of your maximum effort. Now 50% is what I'm doing now. So you can hear my breathing has changed a little bit. And what that can do is demonstrate how you can do a 50% contraction. Now relax, let it go. Go back again and now take your brace up to, let's say 85%. So I'm going to brace harder now so you can hear how it's stopping me from breathing in the same way. And that would be, you know, if I'm a rugby player, I'm going to take a hit. My trunk needs the ability to brace and take a hit in a sport. Or if I want to move my arm or squat with a big weight. And then you could go, and remember, we could do this flat on our back on the mat. Then you could go 100%. And you could literally, and then let it go and practice different degrees of bracing. You could go 20%, 40%, 60%. You know, you could take a client through varying degrees, because during your sports, you're not just going to be bracing, you're going to be bracing at different amounts of effort. And if we can get our clients moving well, moving freely, and then stabilize them using these tactics, then they're more likely to have control during different activities or sports, or even in an accident. If any of you have had a whiplash from a car accident, you come out of it wishing you had strong neck muscles, right? And all the rugby players, you know, hardly ever suffer whiplash because they've got really strong necks. So muscular strength is about protection of organs as well if you were in an accident, for example. So you can then vary by using dead bugs. You're still flat on your back, so you've got a nice base of support. And then the next layer down you can see is prone kneeling. So what did you call it? Bird dogs. It makes me laugh, all these names. Bird dogs, it's prone kneeling, arm and leg extension anyway. Same idea, you can progress them through. You've now taken away some of that base of support. Then you can go to sitting on a stability ball. So we've got them stable statically first. Now we're on the ball, and then even standing on one leg, so the balance side of things. You could then have them on an unstable surface standing, like the Bosu. You could do these with your eyes shut. And there's whole reams of kind of challenging the trunk in a variety of ways, as you can see here, using a variety of tools. It's endless. It's just your kind of imagination, if you like. So a couple of functional screens, and these are quite nice, simple ones. So basically prone kneeling and squatting. So in that position, going from an upright prone kneeling and being able to sustain the spine position as you sit back or your client sits back on their heels. And if they can't, then we would take them through the following. I'm going to teach you some more core progressions. Same with a squat. Can they squat down and maintain that spine line? Or are you familiar with the term butt wink?
Yeah.
You come across butt winking. Whenever I talk about it, I get people going, what's a butt wink? I'm like, it's when your butt winks at you. And so some people don't know, they've never heard it. So if you imagine during a squat, as you're coming down, if the butt winks under, then you lack the ability to control the pelvis and the spine. So all that preparation work with the foresight, spine mobility is allowing you to maybe butt wink later, or maybe not at all. The stability work that we've done in advance is going to get you stronger. So by the time you get to this point where you're getting them to squat, keep the spine still, they should have half a chance. And then the last one, has any of you got enough space on the floor? This is a fun one to have a go at. Have you got some floor space? Do you want to have a go? Right, okay, last one. So this one is to test your client's ability to control a torsal rotation. So we're going to go into a plank position, and your hands shoulder width, so here, like a tricep position, and the feet should be 6 inches apart, no more. And if you watch first time, and the idea is from here, can they put their hand onto the opposite hand without the bum twisting, without rotation? And so it's the fact you've taken a base of support away. Does the body drop or compensate, or can they actually control it? Go on, Jack, you having a go?
Yeah, let's see.
So hands underneath your shoulders, feet 6 inches apart, no more. And then keeping your bum still. Oh, not bad. Try the other way. Yeah. And try and do it with literally, you're going to touch and then come back. Not bad. So what you could do in this example is I might balance a pole, a light pole across the back of Jack's hips, so that when he's tapping his hand across, if the pole is tilting, then that indicates he might want to do the following exercises. But not bad, actually, Luke, Jack. Did I call you Luke? Jack, sorry, Jack. So again, just a couple of tests. I'm going to send you the slides, guys, don't panic. And then you'll have these to play with. So that's your torsal rotation. So it's the ability to keep everything level and not the hips not lift as you take the hand away. So if they struggle with the squats or the cross-pelvic syndrome, then what we can do is take them through these types of exercises to really groove out gross function. So a really simple one would be to elbows on a wall, feet kind of hip width apart, and then as you turn, you've got to try and keep the shoulders and the hips level all the way. So the hips don't go first, and then the shoulders, it all goes at the same time. And then you can take that to the floor. So you're getting these rotating planks. But the key component is the hips and the shoulders must move at the same time. And that's the bit that's tricky. That's the bit that people usually can't do. The hips usually go first and then the shoulders. So when it comes to preparing your clients in a gym, just thinking about the way you use machines. So the image on the left, obviously using a machine with your back on the bench. But then if you look at the image on the right, same machine, same exercise, but without your back on the bench. And that's going to make it 3 times as hard. So it's a great way to play with and adapt exercises even on a machine. I know the machines are kind of poo-pooed at the minute, but they're actually really good for a complete beginner because they stabilize them. But if you then take their back off and then get them to press, then the kilos will probably come down quite a bit. You've got symmetry through to asymmetrical. Now, this is kind of a nice example because I know we've been talking about cleans and squats and deadlifts. Can you imagine asking a client to squat with different weights on either end of the bar? That would be pretty controversial, wouldn't it? But if their strength ratio is not right in the side of their body, that might be a good way to challenge their balance and symmetry. And then you might swap the bar the other way and challenge it the other direction. So it's understanding how to improve symmetry may require asymmetrical prescription for a short period of time. So just the last couple of slides, guys. A big question, but I like to be challenged and I like to challenge everything. And I want to encourage you guys to challenge everything you're taught, and your tutor will throttle me for saying that. But you should be able to challenge everything until you really fully understand it. Should we do core stability work? Well, the core is often inhibited in cases of low back pain, which is, I know, a common problem that you are going to see if you haven't already in your clients. But if the core is unable to engage, then core exercise will help to engage it. So there's a strong theoretical argument for doing core training. However, in terms of the statistics and the studies, there's not a huge amount of evidence suggesting core stability work is better than any other form of trunk conditioning. So what does that mean for you guys when I say that? How do you hear that? Core stability training hasn't been proven better than other forms of trunk conditioning.
Well, for me, people always think, like, people would go immediately to sit-ups and think that that's core training. But I also teach vocals. I'm a vocal teacher, so I have core stability ingrained in me. I don't have a six-pack or anything like that, and don't particularly do a lot of, like I said, sit-ups and things. But core training is like stabilizing. So if you do an exercise where you're standing, even like a shoulder press, standing rather than seated, you're immediately engaging.
Exactly, and that's the point. So to kind of argue against core stability training, you're using your core all the time. Your clients are using them all the time. So the argument is exactly the point that Betty's raising. If they're doing a shoulder press, they're going to be engaging the core. However, to argue for core stability training, it's a really good way to evaluate and specify strengthening certain areas, or even testing and challenging, like the torsional control test that we did on Jack. So they're good ways to test and monitor and then prescribe core stability training, rather than just relying on their overhead press, because their overhead press may be with excessive spinal extension.
Yeah.
So doing core stability training is probably a good thing for PTs to use as a tool to monitor progress and encourage good core stability, so that when they do press. But I'm just making the point, there's no evidence to say that's the best way to do it. There's no research papers. It's all a bit sketchy in the research world. However, it makes sense. It's simple, it's safe, and it's effective and usable for personal trainers. So I think, you've got the two ways of looking at it. But that's exactly what I would say as well, Betty, is along those lines. But just to kind of simplify everything we've spoken about tonight, and we look at all the problems that you might face in your clients over the years, hopefully that you stay in the industry, because it's a wonderful industry. We can release, we can move, we can strengthen, we can stabilize, mobilize, we can uninhibit now. I've taught you a muscle energy technique, and if you do any manual therapy, if it hurts, you rub it. Really simple. The problem isn't what we do about it. The problem is knowing which one of these is the right thing to do at the right time. And by the way, we'll never know the answer until we start addressing things. So we don't know if it's weak or inhibited, or if it's stiff or immobile. And you don't know that, I don't know that, nobody knows that. It's only when we start to apply interventions. So what I'm suggesting here is learn as many tools as you can to improve movement. So rather than just stretching and foam rolling, look at different ways to improve movement, look at different models of testing movement, so that you have a whole repertoire of skills to help you. But being honest, it's all hypothesis, which is a comfort in some ways. So it's not just manage what you see, it's managing things that you can measure as well. So you could use the squat as a benchmark. You could use the deadlift as a benchmark. You could use the Turkish as a benchmark. We could use Betty's lunges and squats as her benchmark, because she's given us one. I would be, as your PT, Betty, I would use your squat and lunge as my measurements, where I'm starting with you, and then you're saying, right, I want to achieve a better lunge for whatever reason, for example. Say, right, brilliant. Let's film you front and side doing a lunge and doing a squat. And they would be my benchmarks. I would add in the 4-sign exercise. I would do the spine mobility drills that we've all done. We could do the core testing we've just done with Jack, and the spine, the squat in the spine, looking at the spine. And now you've all got a whole series of tests. They are biomechanical analysis of your client. You take the videos with their permission, or you cut the head off. And then next time when I see Betty, I say, right, come on, Betty, let's have a look at your lunge. And I film it again. And then I put it in my app, and I put week 1 in, and I put week 2 in, and then I show her and I go, look, see how much better it is now. And she's like, oh yeah, it is, isn't it? Fantastic. Those ab and adduction exercises are really working. So as a trainer, as a coach, your job is to prove to the client that your advice has been successful. Weight loss is kind of an easy one. You measure them, you weigh them, super easy, but you're measuring them. When it comes to movement, running, so Kevin's runners, time and distance, it's easy, it's got a measurement on it. But all clients would come with the desire to move better, to have more strength in movement. And so if we can start off with movement tests, analyze their movement quality, understand their biomechanics on day 1, do the videos of their movement, their squats, their running style, their presses, their, you know, whatever they're doing, add it into our consultation and then monitor that. We can show them really vividly, week 1, week 6, look at you, amazing. And they're like, oh, wow, yeah, oh, wow. And they often don't notice in the early days. They just, you know, when you're with somebody and you don't notice they change, when you're with them all the time, if you buy a dog as a puppy and everyone goes, my God, he's massive. And you don't notice it because you're with them all the time. And I think that's a bit like that sometimes with PT clients. Sometimes you have to, well, you should evidence where your skill set has actually benefited them. You can show them.
I ask a question? Sorry.
Yes, go on, Donna.
So see core exercises, what I find a lot of people complain about their back the most, you know, flutter kicks, low flutter kicks. A lot of people would say all the time their back sore. So what should you do there? Should you avoid that?
Oh, it's a massive question at the end of the session. Obviously don't. If it hurts, don't do it. And then what you want to do, Donna, is understand why their back hurts. Yeah. So
their back wouldn't be like bad pain. It's just, they would just say, oh, it's a bit sore.
Okay, I'm going to play devil's advocate if I may, Donna.
Yeah.
Sore is uncomfortable in my world and you should stop. Yeah. If it's just working, then that's different. So number 1, clarify with that individual, is it uncomfortable or are you just working it? Right. Make sure you get that clear. If you're working it, that's what we're trying to do. If it's sore and uncomfortable, stop doing it. We need to have a consultation. I need to test your pelvis, test your spine mobility, test your core strength, use the stuff I've taught you and anything else you learn, and then say, actually, your lumbar spine's a bit stiff. Let's get that moving well first, then we might go back to that. Mm-hmm. Does that make sense?
Yeah. I just find different people would say that all the time. Flutter kicks, you know, at that. Well, I think they're just saying, this hurts. More uncomfortable.
So,
yeah.
Guys, so you're familiar with the flutter kick? So you mean on your back, right?
Yeah, on your back. Yeah, low.
Legs straight and do that. So what's the joint action?
What's the what? Sorry.
Action.
What's the joint action in a flutter kick on your back?
Hip flexion, hip extension.
Yeah.
It's hip flexion. The extension is the antagonist move, but the primary action is hip flexion. Yeah. So what are the prime movers in hip flexion?
Hip flexors.
The hip flexors. Where do the hip flexors attach? Psoas.
Lumbar spine.
Into the lumbar spine. So your people who are lying on the back doing flutter kicks are loading the lumbar spine because they're using the big hip flexors, psoas that sit into the L1 to 4 to produce that movement. So just seeing if I've got an image. I could show you on Skelly, couldn't I? So the idea being that when they're lying on their back, if the hip flex, the psoas comes up into that lumbar spine, every time they lift the leg, that muscle is pulling on the lumbar spine effectively. They're not necessarily moving that way, but it's loading the lumbar spine because the muscles those hip flexors insert into the lumbar spine. So they're pulling. Can you see how they would pull on the lumbar spine? So it's kind of supposed to work that area. But as I say, you need to clarify, is it uncomfortable or is it just working? If it's just working.
Yeah, I would always say put your hands under your bum.
Yeah.
If you're back. Yeah.
Yeah, could do. But it depends on how much it's hurting. If it's hurting, stop. If it's just working.
I think sometimes they're just going because it's working the core so hard. They're probably moaning a wee bit.
So maybe it's too advanced for them.
Yeah.
So regress it back and then progress them on. That could be a good idea. Yeah.
Yeah. Okay.
So guys, any other questions? Because that's pretty much everything I've got in my PowerPoint. I mean, I can talk for England, but I'm aware that it's kind of tough when you sat looking at a screen, which is why I tried to make it as dynamic as I could. Any questions on anything we've covered? I'm going to send you the PowerPoints. Do you feel like you could go and do the tests? Can you remember all the tests?
I think so.
Yeah. So cross the ankle over the knee. I'll send you the video.
I got cut out at that part, so I'm gonna try and get the whole video to watch it tomorrow because I missed it.
Yeah, I'm gonna. It should have recorded. Yeah, it's recorded, and I'm hoping it will be a long recording. So bear with me whilst I download, upload, and then upload, and then send, and then. But you'll get the recording as well, and I'll send you the handout. And then what I'll do as well, to Naomi's point, is I'll make you a little man image, like a variation on my one, so that you've got based on the tests that I've taught you, I'll do you a little one of them. It'll be less boxes because you haven't done all the tests, but and then you've got something to refer to that will enable you to then use it on a consultation with a client. Would that be all right?
Mm-hmm. Yeah.
So I'll bring it to a close then, and I'll get a little slide print out of the slides sent over PDF. I'll save the recording and get that sent over so you can catch up on that, Kevin. If any of you have got any more questions, let me just pull up. It's not on there. So you can find me on Instagram, Biomechanics_education, YouTube, Biomechanics Education. I do loads of videos. There's a really nice, in fact, let me grab, I've got some free webinars. I'll just stick the links in here. And then you can grab.
Sorry, what's your Instagram name? Sorry, what's your Instagram?
At Biomechanics_education.
Okay.
YouTube is just Biomechanics Education. Facebook, guess what? Biomechanics Education. I've just grab those links in the chat box, guys. There's 3 links in there. To grab a couple of, there's 2 free webinars, and then the squat project is 7 videos based on similar to what we've done here, but there's pelvis, spine, shoulders, nerves, knees and feet, which you could use with clients as well. Actually, it's quite a nice little series, really popular. And I think that's everything. I'm on Twitter. Does anybody use Twitter anymore? I don't know. But the website is, guess what? Biomechanics.education.com. And I've sent you the free stuff that I've done, but if you want to sign up on the website I do a blog every Tuesday, and I'm just literally launching an anatomy series where I talk around pelvic bones, pelvic muscles, pelvic actions, spine bones, spine muscles, spine actions, shoulders, knees, feet. And there's going to be videos that go with them as well. But the videos, I think, will be chargeable. I think they're about £7 the first one. But you can get the blogs free. They're completely free. So they'll have all the info in there as well. Other than that, thank you for staying, spending time, answering, having a go, interacting. If you have any more questions, email me, rachel@biomechanicseducation.com, RACHEL. And if you want me to send you anything, if you want to chat, I was supposed to be over in Belfast next month to do this hands-on, but obviously under the current climate, it's not possible. So I'm hoping to get over, I think it's April is the next planned visit. So if you want to do more, if you want to be a biomechanics coach and learn all the tests, we can give you a level 4 low back pain qualification with that as well, for free, within the diploma. So if it's interests you, then obviously get your PT. When's your exams, by the way? When do you finish your PT course?
27th of November.
Right. Yeah. So yeah, the anatomy side is an interesting one. Knuckle down, word association is ishibum, that kind of stuff is the best one. Or if you look at the history of the anatomy, it can help you understand why things are called what they are, which helps with memory. But okay, guys, I'm going to let you go. Thanks ever so much. Do feedback to Lee, and I might see you next year, hopefully. Otherwise, good luck with your PT qual, and good luck with your businesses. So take care, and I'll speak to you soon, guys. Bye.
Thank you. Bye.
Bye-bye.